Hello, everyone. Good morning. Thank you all for joining us for our 2026 World TV Day webcast. We hope that each of you are doing well on this World TV Day. I believe it is the 44th iteration of World TV Day ever since its official start as a nationally recognized or internationally recognized occasion since 1982, which was the 100-year anniversary of when Dr. Koch first discovered Mycobacterium tuberculosis. So with that being said, let's commemorate this momentous occasion by talking about some important course information regarding our celebration this 2026 World TB Day. So just as a bit of a heads up regarding any sort of questions that you may have that pop up throughout the webcast, participants are encouraged to ask questions of our speakers throughout the training using the Microsoft Teams chat feature. And speakers will do their utmost best to answer any questions at the end of their respective presentations. Any questions that are not answered or cannot be answered may be forwarded to their designated speakers at the end of the webcast. Additionally, we do want to make sure that we provide a photo and video disclosure to all of our participants. This webcast is being recorded and photos and videos may be posted on our social media. So if you are not comfortable with that, please let a Heartland staff member know if you would not like to be filmed or photographed. Most participants do not have the ability to enable their cameras, so that should not be an issue for most. But if for some reason you do have an issue, please feel free to let us know. Regarding the disclosure to learners for 2026 World TV Day webcast, successful completion of this continuing education includes the following: attending 100% of the activity and completion and submission of a participant evaluation. Continuing education has been provided for the following professions: certified health education specialists, certified in public health, Master Certified Health Education Specialists, and nurses. Particularly for nurses, the Texas Department of State Health Services Continuing Education Program is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The Texas Department of State Health Services Continuing Education Program has designated a maximum of 3.25 contact hours of nursing continuing professional development. This activity is a joint providership between the Texas Department of State Health Services Continuing Education Program and Heartland National TB Center. Additionally, for physicians, this activity has been planned and implemented in accordance with the accreditation requirements and policies of the Texas Medical Association through the joint providership of the Texas Department of State Health Services Continuing Education Program and Heartland National TB Center. The Texas Department of State Health Services Continuing Education Program is accredited by the Texas Medical Association to provide continuing education for physicians. The Texas Department of State Health Services Continuing Education Program designates this live activity for a maximum of 3.25 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Also, this event has received no commercial support, and our speakers and planning committee members for this event have disclosed no relevant financial interests. And then, of course, just because this event is accredited, it does not imply any endorsement of any commercial products or services by the Texas Department of State Health Services, Texas Medical Association, or American Nurses Credentialing Center. And the speakers did not disclose the use of products for a purpose other than what it had already been approved for by the Food and Drug Administration. Thank you so much for your time and attention. We are excited to provide you with this learning opportunity and would like to take a quick, and I would like to take a quick moment to invite our first, Miss Sandra Morris, to share her screen and kick us off with a little bit about the state of Texas.
Wonderful. Thank you so much, everyone. And I need to thank the Heartland team as well as our San Antonio Metropolitan Health District folks for really putting on what I think will be a fantastic recognition and awareness of tuberculosis in Texas. So my presentation will be on the epidemiology of tuberculosis in Texas. Please note that the dates that we will be providing today for 2024 and 2025. They are provisional as of today. So let's talk about the incidence and distribution of TB in Texas and where we're seeing transmission of tuberculosis in the state. So from 2018, this bar graph that you're seeing reflects our data from 2018 through 2025. And as you can see that we have been we've been seeing a slow progression of tuberculosis disease incidence since 2020. And unfortunately, we are back to our numbers in terms of what we've seen prior to 2020. Additionally, we are also seeing an increase in our rates starting from 2021 up to 2024. Now, I think quite a few of you may have seen the CDC's presentation on Friday, where it states that for the most part throughout the nation, there has been a slight dip in the number of cases reported between 2025 and 2024. And so this slide shows that we have not seen a dip in the number of cases from 2024. So once again, tuberculosis really remains a public health threat in Texas. So the next slide will reveal our top health departments. And we've also added a correctional facility where we're seeing the highest case count in Texas. And this is no surprise. We continue to see our heavy lifters, which are Houston, Dallas, and Harris County. In looking at these the top three counties, they essentially have the majority of our incidents in TB for Texas. Approximately 35% of our cases are found among the cities in Houston, Dallas, and in Harris County. Sorry, please excuse my voice. The allergies have affected me this morning. And also in the top 10, as I mentioned before, we also included Texas Department of Criminal Justice, where we're seeing that approximately 4% of all cases in Texas for 2025 were identified with TB. Now let's look at our top 10 counties with the highest counts of TB. Once again, with Harris County, Dallas, followed by Tarrant, Bexar County, Hidalgo, just rounding out the top 5. But once again, we see in this slide that not only are we looking at our metropolitan areas for TB, but also our border counties as well. So regarding the geographic distribution of TB cases in Texas, overwhelmingly, 77% of our cases are diagnosed in our metropolitan areas, followed by our border counties, and then, of course, in our non-metropolitan areas. Now, this slide depicts the area that we consider our border areas. This is based on the La Paz Agreement, where there are 22 counties, in more than 22 counties involved in determining our border counties. And so when we look at this slide, we see that the number of cases are primarily identified on the southern tip of the state and El Paso, which is to the far left. So our demographic characteristics that we will be looking at shows that we continue to see what we've seen for many years, that males are significantly disproportionately affected by tuberculosis. And that has not changed. As you can see in the trend, we continue to see a widening gap between the number of females versus the number of males diagnosed with tuberculosis. This slide shows the age groups in which we are seeing tuberculosis in Texas. And unfortunately, all age groups are affected by tuberculosis, from the 0 to 4 years of age all the way to individuals 6 to 5 years of age and over. We see a significant number of our patients diagnosed with TB are among the 25 to 44 years, and then, of course, followed by our 45 to 64-year-old groups. However, although the number of pediatric cases are small, it is worth noting that we are continuing to see a concerning number of children 0 to 4 years of age that are diagnosed with tuberculosis. We saw a significant spike in 2024. The numbers have dropped in 2025, where only 30 children between the ages of 0 to 4 years were diagnosed with tuberculosis. So let's take a look and zero in on what that looks like for this particular age group. And as you can see, that when we're looking at children from 0 to 4, our children that are under 2 years of age are impacted by tuberculosis. This is pretty concerning from a public health standpoint, as many of you are aware, that children that are diagnosed with tuberculosis indicates a sentinel event. And not only that, but we're also looking at the fact that tuberculosis disease in this age group can have a very devastating effect on the child, including tuberculosis meningitis. So here we're looking at our numbers among our non-US born TB cases. In Texas, we continue to see that the individuals who are non-US born continue to be disproportionately impacted by tuberculosis. And here in this slide, while we have seen a dramatic increase in 2022 to 2023 and a decrease in 2024, there's a slight uptick in 2026. However, what we have seen across the board from 2019 through 2025 is that more than 60% of TB cases diagnosed in Texas are among the non-US born. And this slide shows we're now moving into drug-resistant TB. And this slide shows the number of cases that have been diagnosed with isoniazid resistance. And we really don't see a huge difference in terms of 2024 and 2025. But once again, we are seeing quite a number of patients diagnosed with isoniazid resistance. So the next slide really looks at our multi-drug resistant TB cases. And by far, we can see that we continue to see a number of individuals diagnosed with multi-drug resistant TB, which is resistance to at least isoniazid and rifampin. And unfortunately, we had our first case of extensively drug resistant in 2025. The last time we had a case of XDR-TB was in 2021 and in 2022. So now we look at our risk factors. And as we've seen in past years, we continue to see that among our patients, almost 25% of our patients are diagnosed with diabetes. This slide shows 22.9% of all patients diagnosed in 2025 suffered from this condition. Then, of course, a significant number, a much smaller number, I should say, of our patients are below their ideal weight. It is really good to see that the number of patients diagnosed with HIV/TB continues to remain under 5%, which is certainly a shift from what we saw in the early 90s, at the time in which HIV was really a driver of individuals diagnosed with tuberculosis disease. And then looking at our social risk factors, cases diagnosed in correctional facilities account for 13% of all cases in Texas. And that is 170 cases, 170 individuals, I should say, out of 1,295 people were identified in a correctional facility. And when we talk about a correctional facility, we are referring to our federal prisons, our state prison, which is Texas Department of Criminal Justice, our local jails, our juvenile correctional facilities, and our Immigration and Customs Enforcement, or ICE, detention centers. So, in summary, based on the data that I've presented today, we know that tuberculosis remains a public health threat in Texas. We know that all age groups are impacted by tuberculosis. We continue to see a trend of patients that are diagnosed with diabetes. And we also know that non-US born persons continue to be disproportionately impacted by tuberculosis. And of course, looking at our correctional facilities on the previous slide, where more than 13% of our of individuals diagnosed with TB in Texas continues to be impacted by tuberculosis. So in summary, we also have a long way to go in terms of how we are able to effectively prevent TB transmission in Texas. We know that in Texas, when we're looking at our geographic boundaries, whether it's in our metropolitan areas, our border areas, or our non-metropolitan areas, there are challenges in managing individuals with tuberculosis. And so it's really, really, I think we are warriors in terms of the work that we continue to do every day to really meet people where they are when they are feeling their worst, and being able to work with them to ensure that they receive quality care so that they're able to live lives that are meaningful and that they are not continuing to be impacted by this horrible disease. Thank you, everybody, and I will turn this back to Heartland.
Thank you so much, Sandra, for all the information that you shared with us just now. Just as a little heads up, because I'm seeing the question pop up in the chat at least twice, and for anyone who is wondering, presentations that are allowed to be publicly available will be made available about a month from now via our training archives, as well as via our official YouTube channel once the recording has been uploaded. So this will be a good chance for you to subscribe to our YouTube channel if you haven't already done so. And with that being said, we're going to move on to a series of presentations that are going to discuss the challenges of public health departments across the state of Texas.
Good morning, everyone. My name is Tommy Camden, and I serve as a TB Health Program Manager for the City Chest Clinic with the City of San Antonio Metropolitan Health District, located in San Antonio and within Bexar County, Texas. The city of San Antonio is the seventh largest city in the United States and the second largest city in Texas. In 2024, we had 87 persons with TB disease, and this past year in 2025, we case managed 75 new persons with TB disease. Let's start off and just briefly identify two challenges we had at the local level in 2025. Number one, our biggest challenge at the San Antonio Metropolitan Health District in a nutshell has been trying to balance and maintain our TB budgets. It's been a juggling act in 2025, trying to balance our state and federal TB budgets along with limited general fund money supported by the city of San Antonio, combined with a couple of other grants such as the Public Health Infrastructure Grant that is split and shared among several other programs. Personnel hiring has been delayed or postponed to prevent over expenditure in the budgets, or in some cases, positions eliminated in order to balance the budgets. Our local, federal, and state TB budgets have essentially remained flat for many years when our personnel costs continue to rise with cost of living increases, performance pay increases, and longevity of personnel in other cases. As we prepared our fiscal year 27 federal and state TB budgets, we unfortunately had to cut a full-time health program specialist position. Number two, our second biggest challenge in 2025 was data management. The repetitive charting data entry with our local electronic medical record system and combined use of paper charts, also combined with the repetitive data entry into NEDS, has definitely been a challenge. The challenges of using the CDC's National Electronic Disease Surveillance System, or NEDS, are primarily related to interoperability, data standardization and quality, and resource limitations at the state and local levels. In other words, our electronic systems do not talk to each other. Based on what items are needed not only to submit to CDC to be counted, but to also meet metrics with Department of State Health Services, each investigation needs about 575 individual fields filled with anything from easy yes-no answers, dates, and demographic data to more complicated things like medication names, the unit of measures and various tests, and languages spoken. There's a lot of tedious redundancy in things like contact entries, medication regimens, exposure sites, and laboratory reports. While all states now use NEDS-compatible systems, ensuring full interoperability between various clinical and local public health systems remains a persistent issue, often requiring complex data management and validation processes. Our biggest success story in 2025, as simple as this may sound, has been the incorporation of a Wednesday evening clinic and extending our operational hours to 8 p.m. on that particular night. Originally, this began as a temporary fix to address contact investigation issues dealing with a local public school investigation, but quickly blossomed to include nursing and clinical operations as well. Staff were able to take off early on Friday afternoon, so it's been a win-win all the way around for those supporting the evening clinic. For example, during 2025, at this specific Wednesday evening clinic, we were able to collect 253 T-spots, provide 87 nursing assessments or visits, offer 3 MD evaluations, conduct 171 home visits, perform 117 DOTs, collect 248 other blood draws such as CMPs and HIVs or sputum collections, made 21 X-ray referrals. Overall, this has greatly improved our contact investigations and clinical operations, improved customer satisfaction, and improved scheduling flexibility for our TB staff that enjoy an earlier start for the weekends. Thank you, and I hope you enjoy the rest of the presentations today.
Good morning. My name is Mark Tisdale, and I serve as the Chief Nurse for the Houston Health Department's Tuberculosis Control Program. Today, I will briefly share 2 challenges our program faces, followed by a success story that illustrates what can be accomplished when multiple partners work together toward a common public health goal. Program challenge number 1, resource constraints and prioritization of TB control activities. As resources continue to decline, the program must increasingly prioritize core TB control activities. This has resulted in reduced capacity to provide certain services that were previously part of routine program operations. Examples of services that may be impacted include follow-up for B2 immigrants and refugees over 5 years of age with no identified comorbidities, evaluation and follow-up of positive TB reactors over 5 years of age without comorbidities, comprehensive interviewing of clinical TB cases, and expanded targeted testing initiatives. The primary program component affected by these limitations is the ability to effectively prioritize TB control activities. When staffing and operational resources are insufficient, the program must focus on the highest risk cases and public health interventions, which limits the capacity to carry out all recommended TB control activities. As a result, program leadership must continually assess risk and allocate limited staff time toward interventions that have the greatest impact on disease control and prevention. Program challenge number 2. Providing the TB training and education to medical and community partners. The Houston Health Department TB program faces significant challenges in providing comprehensive TB training and education to the wide network of medical and community partners across the region. The greater Houston area includes approximately 140 hospitals, including 21 located within the Texas Medical Center alone. In addition, there are more than 70 federally qualified health centers, along with a large number of private medical providers who may encounter TB cases. Given the size and complexity of the healthcare landscape, ensuring that providers and partners remain informed about current TB guidelines, reporting requirements, and treatment protocols requires substantial time and resources. Limited staffing and competing operational priorities make it difficult to consistently provide training and outreach at the scale needed to effectively support all partners. The essential TB program components affected by this challenge include providing TB-related training and education for TB program staff, other health departments, clinicians, patients and their families, community groups, and general public. Collaborating with medical, community, and academic partners, TB colleagues in neighboring jurisdictions, and staff from other public agencies, example, corrections, social services, immigration services, this all to coordinate patient care and other TB control activities. As the healthcare network in Houston continues to expand, maintaining strong education and collaboration efforts remains critical to ensuring timely diagnosis, reporting, and treatment of TB cases. One potential solution is to host virtual lunch and learn sessions in collaboration with our external partners. These sessions would allow the TB program to provide education and updates to clinicians and community partners in an efficient and scalable format. Virtual sessions would make it easier for hospitals, FQHCs, and private providers across the greater Houston area to participate without requiring travel or significant time away from clinical responsibilities. This approach would also help strengthen ongoing collaborations with medical, academic, and community partners while ensuring that key stakeholders remain informed about TB diagnosis, reporting requirements, treatment protocols, and public health coordination. Now that we've discussed some of the challenges our program faces, I'd like to share a success story that really illustrates the impact of persistence and collaboration in public health. In 2018, a patient experiencing homelessness was diagnosed with tuberculosis. Unfortunately, the patient was in complete denial about this diagnosis and refused to start the TB medication regimen. As a result, the patient was eventually lost to follow-up. For several years, we had no contact with him. Then in 2024, the patient once again became ill and returned to the VA hospital for care. At that point, the TB program worked closely with the hospital to initiate court-ordered management to ensure the patient could receive the treatment he needed while also protecting the community. The patient was transferred to Texas Center for Infectious Disease in San Antonio. With the support of the TCID team, our program was able to present the case to the court and demonstrate why continued treatment was necessary. On multiple occasions, the judge agreed that remaining at TCID was in the best interest of both the patient and the public. After many challenges and years of delayed care, the patient ultimately completed TB treatment 6 years after the original diagnosis. This case truly represents a team effort. It required a coordination between the hospital, TCID, the courts, and the health department. By using every tool and partnership available to us, we were able to ensure the patient received treatment and the community was protected. Finally, we would like to give a special shout out to the organizations that have supported our program and continue to play a critical role in our work. We are especially grateful for the ongoing partnership and collaboration from the Greater Houston Area TB providers, the Heartland National TB Center, and the Texas Center for Infectious Disease. We also want to recognize the continued support from the Texas Department of State Health Services Central Office, Region 65 South, and Region 45. Finally, we want to acknowledge the invaluable partnership of the Harris County District Attorney's Office, whose collaboration has been essential in helping us carry out court-ordered public health interventions when necessary. These partnerships are critical to the success of our program, and we truly appreciate the dedication and collaboration each of these organizations bring to protecting the health of our community. Thank you.
Good morning. We're honored to be here today to present as part of the World TB Day webcast. Topic is challenges of public health departments. Our first challenge is completion of contact investigations in select populations. Part of our issues pertain to identifying contacts and completing evaluations, the starting and completing of LTBI therapy in appropriate persons. Some of the issues that we've encountered include use of aliases, unique languages. We were unable to find translation for several months in one particular case. Often the clients are unwilling to share information. We've even experienced a little bit of hostility, some anger at our repeated attempts to promote treatment, and generally a lack of trust in government entities. Potential solutions that we have thought about include collaboration with employers. They tend to have a better rapport with some of our clients, utilizing community groups such as churches that are seen as trustworthy, reminding ourselves that we need to remember cultural literacy when we are working with patients from different cultures and countries. And sometimes I think we need to just remind ourselves to give our clients some space and then try again later, perhaps with a different individual, or maybe sometimes just the space will give them an opportunity to not feel so rushed. The second program challenge that we would like to present is managing LTBI as a reportable condition. The question is, are we really getting quality data? Our department has a very large number of referrals, excluding the electronic disease notification for refugee patients. Data can be very time-consuming as we enter into multiple databases. We also have a manual reporting processing. Our outside reports are received via either fax or email. We've got to review the information to determine if it's a referral or simply a report. Determine is all the pertinent information included. Some of our potential solutions include leveraging a different digital technology to manage our referral processing, strategize better processes for our data entry, certainly providing education on full reporting criteria to our referring entities. There is still very much clarity that is needed on defining latent TB infection for reporting purposes. We can also consider what other programs are doing. Finally, a program success story we would like to share. In 2013, we identified a large outbreak in the unhoused and shelter population here in Dallas County. We had about 189 active TB cases between 2009 and 2016. These were total cases in the genotypes, but the majority of these were found in Dallas County. We collaborated and continue to collaborate with the Department of State Health Services, ourselves, Parkland Hospital, the Dallas County shelters. CDC was the big factor in the success of this story as well. We established a task force here. Again, CDC sent in a consultant. We identified a point person in each shelter that would work specifically with us on this matter. We hired new staff, including a nurse that was specifically assigned to the unhoused population. We ultimately came up with and agreed upon mandatory testing for new shelter residents. We developed and distributed a shelter infection control plan, networking with community groups who also work with the homeless, including there's a City of Dallas group that we have worked a great deal with and has been very helpful. Maintaining and continuing to improve ongoing relationships with our shelter staff and including annual education for the staff. Cases in the unhoused shelter population have decreased significantly since that time frame. During the outbreak, we averaged 27 TB cases in the homeless or unhoused per year. In the last years, 2017 through 25, our average is 10 per year. So we're very proud of that continued success and are happy to share this project with you. And thank you so much for inviting me. And if you have any questions, please feel free to email us. And thank you so much for having us.
Good morning. My name is Annette Gonzalez. I'm the nurse practitioner and program manager for the City of El Paso Department of Public Health Tuberculosis Program. Today I'm going to talk to you about the challenges we face here at the City of El Paso Department of Public Health, along with some of our success stories that we've had here. Our first major program challenge is geographical isolation. Our tuberculosis specimens must be transported to multiple laboratories located outside our immediate service area, which creates logistical and operational challenges. Specifically, sputum specimens are sent to the Texas Department of State Health Services laboratory in Austin for processing. Our CBCs and CMP blood samples are sent to the South Texas laboratory in Harlingen, Texas. Interferon gamma release assays, or IGRAs, are sent out of state to Quest Diagnostics in Memphis, Tennessee. Additionally, drug therapeutic levels are sent to the University of Florida for analysis. Because these laboratories are geographically distant, transport times are extended, increasing the risk that specimen integrity may be affected. Factors such as extreme weather events, shipping delays, and transportation disruptions can further impact turnaround times. These delays can result in delayed diagnosis and delayed initiation of treatment for patients with tuberculosis. Ultimately, this prolongs the infectious period and compromises our ability to respond effectively from a public health standpoint. Our second major program challenge is that El Paso is a major travel and international border hub. Due to its geographic location along the U.S.-Mexico border, we serve a highly mobile population, which significantly affects continuity of care for tuberculosis patients. Many of our patients are only temporarily in El Paso. Some are passing through while traveling, others initiate treatment here and then return to their home country. Some continue traveling within the United States to other states or destinations after starting treatment with our program and are lost to follow-up. Additionally, immigration policies can affect a patient's ability to remain in one location long enough to complete treatment under our supervision. This high level of mobility directly disrupts continuity of care. Patients may begin evaluation, diagnostic testing, and treatment with our local health department, but then relocate before completing therapy. When care is transferred across jurisdictions, whether across state lines or internationally, there is increased risk of delays, communication gaps, treatment interruptions, and challenges in ensuring appropriate follow-up. As a result, patients often do not complete the full continuum of care within the same health department, increasing the complexity of case management and public health coordination. Another critical factor involves funding constraints and resource utilization. For each new TB patient, approximately 60 to 70% of allocated program funds are typically expensed during the initial evaluation, diagnostic workup, and care coordination phase. When patients relocate before completing treatment, the resources invested during these early stages are not proportionately recovered. Furthermore, reimbursement for care provided is not properly aligned with our local health department under current funding formula. Many patients who leave El Paso also do not meet the greater than 90 days in the United States requirements needed for certain grant funding eligibility. As a result, although we initiate care and expend substantial resources, these cases may not count towards funding adjustments, which directly impacts our program's financial stability. Overall, the high mobility of our population, combined with funding limitations and policy-related barriers, disrupts continuity of care, complicates case management, increases the risk of treatment interruption, and presents ongoing challenges in ensuring treatment completion, maintaining public health oversight, and securing appropriate funding support. Despite the challenges of geographical isolation and high patient mobility, the City of El Paso TB program has become a regional leader in education, collaboration, and tuberculosis prevention across a complex tri-state border area that includes Texas, New Mexico, and Chihuahua, Mexico. A key component of our success is our partnership with the Heartland National TB Center. Through this collaboration, we are able to provide TB infection and disease management trainings across jurisdictions. This supports standardized, evidence-based treatment practices, aligns providers across borders, and strengthens coordinated, comprehensive patient care. We have also developed strong local, state, and federal partnerships that enable adequate TB care. This includes collaboration with the Centers for Disease Control and Prevention, especially the San Diego and El Paso Port Health Stations under the U.S.-Mexico unit. We work closely with the New Mexico Department of Health and local providers in New Mexico, as well as healthcare providers in Chihuahua, Mexico. Additionally, our partnership with the Juntos program strengthens binational referral and continuity of care efforts. This coordinated cross-border infrastructure allows us to effectively manage TB in one of the most geographically and politically complex regions in the country. Thank you for your undivided attention. As mentioned previously, I am Annette Gonzalez from the City of El Paso Department of Public Health. If you have any questions, please feel free to contact me at my email provided to you here on this slide. Thank you.
Good morning. My name is Emily Pro. I am the Regional Medical Director for Public Health Region 11, located out of Harlingen, Texas, down in South Texas. And today I'm going to be talking about the challenges of public health departments. I'm going to give you a little bit of Public Health Region 11 flair. Hopefully my colleagues have given you a sense of the challenges that they've faced, but hopefully this will fit right in with what they have said. Our program challenge number one that I wanted to discuss today is we receive funds from the state, and these funds have to provide TB services. Well, in these TB services, we do have to get chest x-ray and lab. And although we can send lab testing to our lab in Austin, for radiology, this is sometimes a challenge for us. The resources that are provided to us don't include radiology or some lab tests, and we have to develop contracts at the regional level or at the local level to obtain these services. And sometimes, well, not every company really wants to contract with us. It's not necessarily cost effective for radiology services, especially in these rural areas. They prefer urban. In some of the counties that we serve, there's maybe no hospital. There might be one or two physicians' offices, maybe an FQHC, a federally qualified health center. So definitely it's a little bit more complicated to have a mobile x-ray come out and drive a long way in order to take one or two chest x-rays. So this is definitely a challenge for us in Region 11, and I'm sure in some of the other rural areas that we serve at the regional level. We do have 2 mobile x-ray contracts that have been huge help for us in the region, and they have been able to provide some good coverage in our rural areas. There's always from time to time the team brings up, what about some of the rural areas of Webb County? What about some of the rural areas in Zapata? And sometimes we do have some patients that are not mobile. So this is definitely times where we need to think about how we can get the chest x-ray so we can make the best call from a physician's perspective. The second challenge I wanted to discuss today is in these distant or rural communities, providing DOT is sometimes not necessarily very safe. Our staff might have to travel up to 2 hours each way to see patients, for example, if they go to Beeville. And it's sometimes hard to hire staff in these remote areas. Another thing that has come up living along the border is when you talk to people, it's like, well, Mexico's just 10 minutes that way. You just got to cross the bridge. And the cell signals might not always be reliable. When I started my job, I was like, oh, y'all have Verizon, or maybe there's different phone companies that we tend to use because we won't be able to get the welcome to Mexico text message and we'll be able to conduct our jobs. So our state cell phones do not work in Mexico. And even if we are still in the US, getting closer to the border, sometimes we do lose signal. And this has caused some issues with either VDOT or just our staff that are checking on some of the patients, providing DOT or our nursing assessments. We do use a buddy system, and this has worked very well for us. And we tend to use these if we do know that if either it's a new patient and we don't know what the living conditions are, or maybe we already know that it's a community that tends to either have some drug use issues or a community where there might be some lower income housing. So there's always important to be at least 2, and that way it provides security and safety to our staff, which is first and foremost. Now, I couldn't choose just one success story, so I want to show off the team in Region 11, and I wanted to say that our staff have been able to successfully treat 2 patients with confirmed TB disease and preventively treat 5 patients diagnosed with LTBI. We're also addicted to crack cocaine. Our team has partnered with our binational TB team to have pediatric patients who are hospitalized in the US complete their treatment in Mexico. Also, we have been able to help patients establish a medical home and provide diabetes treatment while on treatment. There's many times where we have patients who have chronic illnesses, and being in a rural area, they might not have a PCP. Maybe the only FQHC has months of wait, and our staff being in that area are able to make some phone calls, do all the legwork to really help them get an appointment, because on their own, they weren't capable of doing it. It was just too overwhelming. So these are some of the success stories that we have with our team. Any questions? I do want to have a big shout out to all of our Public Health Region 11 team. They always do a fantastic job, go above and beyond, and work very well together. So I wanted to thank them for all their work and wish everybody a happy World TB Day. Thank you.
All right. So I saw a lot of good comments in the chat about how relatable some of these issues were throughout the state of Texas. So I'm glad to know that you found a little bit of some of the content that was being shared across all of our speakers' presentations. So with that being said, I'm going to go ahead and invite our next speaker, Jackson Smith, to go ahead and start sharing his slides, where he's going to talk to everyone here about the efforts that TCID is doing in empowering the future. So Jackson, I do have your slides on standby if you need them. Can you hear me?
I can hear you, Lauren. And yes, if you display our slides, I'll just let you know when to switch them off.
Of course, of course. So here we go, gang.
Thank you. All right, good morning, everybody. My name is Jackson Smith, and I'm here with the Texas Center for Infectious Disease. I'm just going to throw this filter off. So everybody is probably aware of us, at least on this stage. We are the only TB hospital here in the country. And for those of you watching here in person, this is where you're located right now. I'm really honored for this opportunity to present on the public health internship program. This has been such a rewarding project for TCID, not only for our community specifically, but I think for TB awareness overall. Next slide, Lauren. So I have been working with TCID since 2022. I started as a public health fellow through the DSHS Public Health Fellowship. Shout out Emily. I hope she's listening. That being said, when I finished my fellowship, I was hired here on full time to assist the community relations department through community outreach. I have been doing quite a bit of outreach, and honestly, that's where I've gotten a majority of my interns from. So DSHS typically has about 40 state interns throughout the entire state. And at the current moment, we have 13 full-time interns who are working with TCID. And so I get a lot of questions. How am I locating these individuals? How am I finding these bright young minds that are going to be shaping the future next? And it's all through my outreach. I do a lot of health and engagement fairs. I bring on universities to come shadow and do tours of our campus. And through showing them the work that we do in our day-to-day lives, and really truly my passion and how much we care about the patients we serve here at TCID, we've been able to get just amazing interns to come in and support us. Next slide. So I want to talk about specifically the trajectory of the internship program. In 2022, there was one fellow. In 2023, there was two interns, which were actually fellows at the time. That was me and the two fellows who were here in 2023. But in 2024, we did have two interns who were here throughout one semester. But starting in spring of 2025, I started with a cohort of 4. I went to a cohort of 8 in the summer. By the fall, I went to 10, and now we're currently at 13. Next slide, please. So this program has reached through so many different universities. We have Texas A&M, UT Austin, Texas State, UIW, UTSA, UT Health Houston, UT Health San Antonio, and so many universities, even some outside Thomas More and Grand Canyon University, which are outside of the state, where we're getting just amazing interns from. Next slide, please. So, and then y'all can go ahead and skip this slide as well. So with that being said, I do want to share about 2 members who are not here today. Some amazing members, Miss Maya Reed and Miss Mithrakama. So both of them are interns with the University of Texas at Austin and absolute data geniuses. Next slide, please. This will show you the poster that Maya and I were able to create last summer. She was with us full time in person for one semester. By the end of her semester, she developed one poster, and we've already had it accepted at 6 conferences. She has then gone to lead our data visualization team, and working with Mithra, both of them at UT Austin, have been doing so much data analysis for us. Like I said, they're both hybrid, but they're assisting with so many research projects that have really pushed not only myself, but Dr. Kizelbosch's projects and Dr. Vasquez's projects as well. Next slide, please. So, lastly, outside of the 13 current interns we do have 5 full-time junior board members. So our junior board consists of high school students, all juniors and seniors. And the 2 at the top of that left photo are our seniors who are both, one's been accepted into Emory and one's been accepted into Rice University. Our junior board has worked with us to fundraise, to do TB awareness campaigns. They were just here 2 weeks ago putting together Easter egg baskets and Easter eggs for Easter egg hunt. All high school students who I connected with through an amazing nonprofit called Students of Service here in San Antonio. Next slide, please. So I do want to kind of just discuss that we have 3 capacities. Our interns can come and help with patient activities, working with Karina Escobar, our activities coordinator, to really just bring smiles to the patients. We've had the zoo come, different dances, and different bands come. We've also done spiritual courses, Bible studies, Quran classes, physical classes, community outreach, which has really pushed our marketing, our TB awareness, TB education, and really just helped our nonprofit just grow and grow. And then our clinical research, which you've just seen how amazing Maya has been doing. We've been able to develop a lot of research posters and some papers last year as well. So next slide, please. I think I can discuss how amazing the internship is, but I would love for y'all to hear it from some interns currently. So the first one is Miss Mariana Morin. She started with us last spring of 2025, but is still a full-time intern to this day. She is a senior in medical humanities with UTSA and just an amazing individual. So if you wouldn't mind, I'd love to welcome to the stage Miss Mariana Morin.
Hi, thank you, Jackson. I first thought I'd open with a quote since I've recently been reading Everything is Tuberculosis by John Greens with my peers at book club. But the more I thought about it, the more I realized what matters more than anything are the voices living through TB. It's knowing what they had for lunch, it's knowing how old their children are, and it's listening to why they love San Antonio and how it reminds them of Western movies. It's hearing them share their stories to inspire, raise awareness, and connect. Those are the moments that stay with me at TCID. Tuberculosis to me has never been just about medicine, it's about people. People who miss their families, who think about home, and to hold on to their routines and memories. When patients share those stories, those pieces of themselves, their words carry more meaning than any book I could ever read. It's their stories that have reshaped how I understand tuberculosis. They remind me that this has never just been about curing a disease, it's about supporting the person living through it. Over the past year, what has inspired me the most is working one-on-one with patients. I've truly gotten the chance to know them and hearing about their journeys, not only through TB, but through life. It is in these ordinary human moments that have been not only personally inspiring, but have also led me to pursue medical humanities. I'll never forget when during an emotional art therapy workshop, a patient worker told me I deserve love no matter what, and another showing me a Bible verse to prove that. And if any of you know Mr. Hall and Mr. Quintero, then you know that's the kind of attitude they carry with them every day. It is in those moments I saw once again the resilience we have here at TCID, and I knew I wanted to share that. Being here, I've learned to not give into the fear and stigma surrounding TB, and I credit that to each patient I've gotten to connect with. With that, I've been stunned by the lack of knowledge in the community and even amongst my public health peers surrounding the world's most infectious disease. For my internship showcase project, I made it my mission to share the human experience of TB with the community in hopes of helping close the gap created by stigma. I called it Project Together, Crafting Connections Through TB Awareness. I wanted an opportunity for them to share their stories and showcase their talents while also strengthening the community relations department through the proceeds we raised. We collaborated with TCID, and by accident, we found the right name. I had asked a patient to draw a logo for me, and he misheard me and wrote Love TCID. I chose it as yet again another reflection of the positivity and heart that runs in this community. The patient workers created handmade goods while I focused on sharing their stories and creating informational materials to raise awareness. Overall, the most common theme was that the patients wanted the community to know that they're just people too. By the end of the project, we had sold out of all our handmade goods, but more importantly, had had meaningful conversations with the people who hadn't even realized TB was a prominent infectious disease and is being treated right down the street. As for my own journey, I'm grateful to be graduating this December, and until then, I look forward to continuing my work at TCID while also serving as volunteer recruitment chair for the BICA-MS committee with the National Multiple Sclerosis Society, and of course, continuing my studies. I'm incredibly grateful for all the opportunities and people like Jackson, Christina, and especially Miss Karina who have shaped my experience. I started by saying I didn't want to open with a quote, but I'd like to end with one, because sometimes the right words can help carry those voices further. With that, John Green reminds us we can do and be so much for each other, but only when we see one another in our full humanity, not as statistics or problems, but as people who deserve to be alive in this world. Thank you.
So next, I'd love to welcome to the stage Miss Ariel Villa Senior Ergo. She'll be graduating with her master's in public health from the University of Texas Health Houston this August, and just an amazing individual. So I'd love for her to share your highlights. Thank you, guys.
Hello, everyone. So during my time as an intern, I have in one semester, I raised over $5,000 for the 5K. I was able to present our research at a conference that was broadcasted in Guam. And I also worked on a manuscript that is going to be published soon. I think the staff at TCID has given me so much support even beyond my internship experience. And they continue to inspire me and remind me why public health professionals need to stay resilient and why community is so important when serving underserved communities and vulnerable populations.
And lastly, I'd like to welcome to the stage Miss Audrey Torres. She is a sophomore at UTSA and really just a genius. She was helping do research as a teenager with Casamet High School, and I'd love for you to hear her insights as well. So, Miss Audrey Torres.
Good morning, everyone. I would like to first start by sharing a little background information of kind of how I found TCD. I actually grew up literally just down the road from the center and spent my whole life passing the building without fully knowing the incredible work that was happening inside until just about a few months ago. My journey here as a clinical research intern started through a community connection with Students of Service, a group focused on connecting middle school and high school students to volunteer opportunities in the community. And through them, I was lucky enough to be connected with Jackson and the team. After my very first tour as a public health student, I knew that I wanted to be part of the work TCID does for the patients and for their community. Originally, I came here with an internship background in molecular medicine research, and I spent a lot of time looking for the how and the data behind disease. But as you heard from Mariana, my time at TCID has introduced me a whole new side of health. It has allowed me to grow my research experience while introducing me to the deeply meaningful human side of the field. One amazing experience so far has been working with our junior board, where we mentor high school students about brainstorming those activities and supporting our patients' well-being. It has taught me that while yes, science is vital, the heart of medicine is about listening to the community and advocating for the people behind those statistics. To me, TB isn't just a pathogen anymore. It represents the resilience of the individuals and the families right here in our community. I've learned so many vital skills here, not just academically, but in my professional development, ultimately bridging that gap between the data and the patient compassion. The mentorship and support I've received with the team at TCID has been nothing short of amazing. And as I continue my journey towards a career in medicine and public health, I am more energized than ever to ensure that health literacy and high quality care are accessible to everyone. And so grateful for the TCID team for allowing me to have the opportunity to grow into the compassionate professional that I aspire to be. Thank you.
Guys, thank you so much. And if we could just get to the next slide, please. So I'd like to end on something very special. While Mariana, Ariel, and Audrey were here to speak and to share their stories, I just would like to highlight some other amazing individuals who just have assisted us since last spring. First one up is Miss Zena Idris, everybody. She's an absolutely amazing genius. She is getting her master's in public health with UT Health Houston. Last summer, she started with us and she connected with Dr. Vasquez and was able to shadow with her. And me and and Zena worked together and got a case study prepared for Dr. Kizelbosch that will hopefully be presenting soon. She currently works for ACOG as an educator, and just huge plug for her and her program right now. She's doing absolutely amazing, and I'm so, so proud of her. So this is Zena Idris, everybody. Thank you. The next one up is another summer 25 intern. This is Miss Miranda Cano. She was a DSHS Public Health Fellow in 2023. As she finished up her fellowship, she moved to San Antonio. She is with UT Health San Antonio. She's finishing up her master's in public health, and she is a freaking rock star. She got our social media going, just health education genius. I could not be more proud of Miranda Cano. She has such a bright future ahead of her, and just thank you so much. And I'm really excited for this next one as well. Come on, Miss Kalechi Adejo. So Miss Kalechi Adejo worked here. Miss Udoka, Miss Tawana, wherever y'all are watching. Kalechi is, she started with us last summer, and she's getting her master's in public health with UT Health San Antonio. And she worked with Udoka and Tawana, our physical therapy team here. And she got us connected with Concord University to establish us as a full externship site for their PTA program. Not only that, she set up discharge packets for them and assisted them with really just getting just amazing projects started. I cannot thank Kalechi enough for her time here. She has been absolutely vital, and just thank you so much. Thank you. Next up, I have a senior from the University of Texas, San Antonio, Miss Elena Book. She will be graduating soon this semester and has already been accepted at UNC Chapel Hill. She is hoping to go for her master's in epidemiology and is just another genius. She just helped us retranslate a 13-year-old over 100 slides presentation, and she is just absolutely amazing. I cannot be more proud of Elena than your assistant so far. You've got such a bright future. Thank you, Elena. Next up, I have one more intern from this current semester, Miss Daniela Beretta. She is a healthcare administration major from the University of Texas, San Antonio. And she's not here because she needs to graduate. She's here because she wants to work. She wants to help, but she wants to help her community. She has a background in marketing, a background working within government affairs. And Daniela is a health education just insane specialist. Her marketing skills are amazing. Where Miranda started our Instagram, Danielle is carrying it. So I could not be more proud of her as well. She's just so smart and such a genius. So thank you all so much. Next up is Miss Moran Mai. She is with Texas A&M. Miss Moran drives from Austin every other week, and while still traveling to College Station, she comes here to San Antonio and assist us with our projects. She was a physical therapist in India and is additionally assisting Ms. Udoka, Ms. Tawana, and our medical director, Dr. Kizelbosch, in preparing some posters and presentations for different conferences, really just highlighting the amazing work our PT program is doing. So I couldn't be more proud of you. Thank you so much. And next up is another one of my children. It's Dr. Aisha Salim. I could not be more blessed to be connected with her last fall. She is a pharmacist from India and a TB survivor. She's amazing. Her ideas are just so creative and so fantastic. She brought Quran classes to our patients. No matter where our patients were coming from, she helped them connect for their treatment and just find peace. And I couldn't thank Dr. Salim more. She has been so crucial to so many of our programs. And this is her second semester with us, and we couldn't be happier. I would keep her as long as I could, if I could. So, Dr. Aisha Salim. My pleasure, thank you. Next up, we have Mr. Jose Gonzalez. He just graduated last semester with his bachelor's community health education from University Incarnate Word. This is the most consistent man I've ever met. So professional, so polished. He's amazing. He has been such a help to so many of our projects. And in all honesty, we're so busy in the fall semester with different holidays and different events. This was something I knew I could always rely on. And I'm just so grateful for Jose. He also helped develop a poster for NTCA for Dr. Vasquez and Dr. Kizelbosch last semester. Just an amazing individual. Next up, I have Miss Ashanti Brantley. Come on in. So she is a senior with the University of Texas San Antonio. And last semester, I wanted to hire her really bad. I waited just a small second, and she accepted another internship for her graduation hours. She worked with Prevent Blindness and said, I still like y'all. I'm going to come out and help as much as I can. And sure did she. She has been so vital. She's helped with so much. She's been such a big support. Doing 2 internships with a full-time job as a full-time student. This is a genius. She's absolutely amazing, and I could not be more proud of her. Mrs. Shanti Bradley, thank you so much. And last but certainly not least, it is Chardonnay Cooper. Mr. Chardonnay came with the Texas State Bobcat Shadow last spring. Liked it so much, came back and volunteered for the 5K. Liked it so much, I said, I need you full time. I brought Chardonnay in as an intern full time this semester, and he has been such an incredible support with our Photo Boys project, with really just the graphic design skills, and your creativity is amazing. Such a polished and educated young mind. I'm just so proud of you. And yeah, Chardonnay Cooper. All right, guys. So that's everything. If y'all have any questions, we're really grateful for this opportunity to highlight us. Actually, just keep it on the slide. We do just want to just show you all our 2025 family here at the TCID. This is the Public Health Internship Program, and I could not be more proud of all of us. So these are the bright young minds joining the healthcare field that have all been affected by TB. So thank you all so much for this opportunity, and I hope you all have a great rest of your day.
Thank you so much, Jackson. It's lovely seeing all the bright young minds that are coming to us very, very soon. Hopefully, we get to interact with them a little bit more as the years go on. But in the meantime, while we wait, let's go ahead and invite our next speaker on board. This would be Dr. Riti Sharan.
See if I can do this. Are you all able to see the slides?
Yes, ma'am.
Okay. Awesome. Well, thank you so much. Good morning to everybody. And I'm truly honored to be joining the Heartland National TB Center's World TB Day webcast. And I think today's theme is especially meaningful for all of us because I think ending tuberculosis is not just a scientific challenge, it's a human one. And while we have made tremendous progress in the TB research, the reality is that sustaining and accelerating this progress really depends on training, mentoring, and empowering the next generation of scientists. And that's why the topic today that I wanted to speak about is why do we need to train the next generation? So at Texas Biomedical Research Institute, we are really uniquely positioned to support this mission. We are an independent nonprofit research institute with a very strong focus on infectious diseases. And we are really supported by a large and diverse scientific community here. And what makes Texas Biomed special is the integration of the advanced infrastructure, the high containment labs, animal models, and the translational research programs, and most importantly, a really collaborative culture. And so this environment really allows trainees to not only learn the cutting edge science, but it also allows them to see how the discoveries they make can move from the lab to the real world impact, which I think is super important in TB research. And so despite decades of research, we know that TB still remains one of the world's leading infectious disease killers. And as seen here, there was a 3.1% increase in TB deaths in 2024 versus 2015 in the US. And if you notice in the brackets right below it, the target was actually to have a 75% reduction by 2025. And if you see right below that, the panel shows the estimated TB incidence rate in United States per 100,000. And we see a consistent decline up to 2020 in the last decade. But now we are seeing an increase in these reported cases. So the challenges are really complex. There is also drug resistance, there is co-infections, there are social determinants of health, gaps between lab research and patient care. And really, these challenges cannot be resolved with any one single discipline. They require scientists who can think across boundaries, who can understand microbiology, immunology, clinical care, and public health. And that's exactly the kind of training we are trying to provide in the program that I'm going to mention in my next slide. So the Interdisciplinary Next Gen TB Research Advancement Center, or INTRAC, was created to address this need. It is a very comprehensive training and research initiative that is designed to prepare the next generation of TB researchers through this interdisciplinary education and give them a hands-on experience in TB research. And our goal really here is to bridge the gaps between the disciplines, between the lab and the clinic, and between research and the real-world impact. And here I just wanted to summarize the goal. So at the heart of Interact is a very simple but a very powerful goal, and it is to help the trainees understand truly the complexity of TB, not just as a pathogen, but as a disease that affects real people and communities. We want participants to ask better research questions that are really grounded in the real-world context. And just as importantly, we want to ignite that passion, because meaningful science really comes from researchers who are really deeply connected to the impact of their work. And so this program is able to create these new tools, approaches, and strategies to advance training in a personalized way for participants and cater to their needs and what we can help them with to do their research better. And so Interact is structured under the leadership of Dr. Larry Schlesinger, who's the president and CEO of Texas Biomed, and it is structured through several specialized cores that are listed here with their leaders. And each of these core really contributes a very critical piece of the training experience. So we have career development and biosafety, to imaging, animal models, and clinical research. And each of these cores is able to provide a theoretical knowledge, a course, as well as a hands-on learning. And what makes this model really powerful is the integration of all these cores together. So trainees are not just sitting in silos and learning their courses, but they experience how each component connects with the broader TB research ecosystem. And we are really blessed to have these leaders here at Texas Biomed who are really driven, passionate, and driving the next generation of TB researchers to do their best. And so one of the highlights of the program I wanted to bring to the forte was our intensive week that we did last year. It was a fully immersive experience where the participants engaged in hands-on training, in lectures, and the real-world exposure over a couple of days. And it was really designed to accelerate the learning and provide a comprehensive introduction to TB research in a very short, focused, but intense time frame. And so our participant demographics really reflected the diversity that we want to ultimately cultivate in the future of TB workforce. So majority of these were trainees, but many from institutions outside of Texas Biomedical Research Institute. And I think this diversity is important because different backgrounds and perspectives really enriches the learning experiences, and it is able to foster collaboration between different institutions, disciplines, and researchers. And it is also able to address some of the gaps that affects the more broader connected TB research community. And so the goal of this intensive week is to provide the participants with really an intensive, immersive training experience that combines these different courses and engages them and asks them to talk with each other and share their learnings. And so the way the intensive week is structured, it is a very carefully structured course that balances both theory and practice. And so participants engage in hands-on courses, didactic sessions. We have facility tours of our primate research center as well as BSL-3 behind the scenes to really see how the high containment labs function and what is the engineering that goes behind all those safeties, as well as seminars from leading experts. And very importantly, we also incorporate assessments. And this is how we measure our learning. And we want to ensure that the participants are having a deeper and an integrated understanding. So we have a pre-course assessment where they rate themselves according to their familiarity with the topic of confidence or a skill. And then we have a post-course assessment, and they're able to judge themselves how they fared during the training and if they are now better and they know how to perform those skills in a better scenario. And I also wanted to pinpoint here the seminars that were conducted, which were very well received, and we hope to repeat them and get some more experts in. So Dr. Luis Barrero was able to talk about uncovering the molecular basis of immune variation in humans, and Dr. Elsie PNR was able to talk about the 3D in vitro models of TB granulomas. So really bringing in different fortes and really stemming those seeds of thoughts into the researchers. So it's not really a very passive learning, it's a very active, experimental, and highly interactive learning course. And what truly sets INTRAC apart is the opportunity to connect research with real-world patient care. So participants visit field sites along the Texas-Mexico border at Dr. Blanca Restrepo's lab, where they see in real time how TB impacts communities, how samples are collected, how they are transported and handled. And so it takes them away from their lab and really get the real-world understanding of how things work out at the border. And then they also get an opportunity to train at the Texas Center for Infectious Diseases here in San Antonio with Dr. Lisa Armitage and her staff. And these experiences allow these researchers to step out from their labs, step out from their silos, and connect the science with the human experience of TB, which is incredibly powerful and a very important tool that researchers should remember to keep thinking about, especially in TB. And so finally, one of the very important components of INTRAC is our annual patient conference. This brings together patients, clinicians, and researchers in the same space. And I think it creates a really unique opportunity for shared learning, where researchers hear directly from the patients, and then patients become active contributors to the research conversation. So this is where I think science becomes truly collaborative and where we begin to see the future of TB research taking shape. So this is a snapshot from our 2025 INTRAC patient conference, where we had a total of about 70 attendees, and we had 3 TB patients who are past their first phase of treatment and hence non-infectious, but still recovering physically and emotionally from the TB sequelae. And so there were delays in diagnosis, anxiety, depression, isolation, difficulty of taking such high number of pills, coping with their side effects, and each of these patients was able to provide their unique perspective to dealing with this really difficult experience. And then we also went ahead and interviewed their family members to share their own associated experiences and stress. And in closing, I wanted to just add that if we are really serious about ending TB, we must be equally serious about investing in people, in trainees. And INTRAC represents one step towards building that future through the collaboration, mentorship, and a very deep commitment to training the next generation. And if you're interested in joining our program or learning more about it, please feel free to contact me, or there is a link provided here that you can visit, sign up for the newsletter, and start becoming a part of this very important initiative. And with that, I'm going to end my show. Thank you.
Thank you so much, Dr. Sharon. It is an exciting time over there at INTRAC and Texas Biomed, and we thank you so much for your time and your attention regarding the World TB Day, as well as with your program and how we are fostering the next generation of TB researchers. So, as you can see, you're getting a lot of accolades in the chat, so I'd like to echo them. Thank you again for your time. And now I would like to invite our next speaker, Dr. Elizabeth Howard, who's going to talk with us about how internally within DSHS we are fostering the next generation. All right,
Hi,
Dr. Howard, I see your slides and I hear you.
Hi, good morning. I'm Elizabeth Howard. I'm the program director for the Texas Department of State Health Services Preventive Medicine Residency Program. And I'm excited to follow Jackson Smith and the TCID interns and also Dr. Sharon to continue this conversation about training the next generation in TB care. I have a few minutes with you to share an overview of the preventive medicine residency program and then specifically about the training residents receive and the activities that they participate in related to tuberculosis. The DSHS Preventive Medicine Residency Program's mission is to prepare the next generation of physician leaders for population-based medicine as practiced in a public health setting. So this program was founded quite a long time ago, actually when the specialty of preventive medicine was also founded, and its aim, again, is to train physicians in public health. The American Board of Preventive Medicine is one of 24 recognized board specialties. And so our training program, it's 2 years. It's accredited by the Accreditation Council for Graduate Medical Education, or also called ACGME. Residents, in order to enter the program, must have completed medical school and have successfully completed a minimum of 12 months of clinical training prior to entering the program. And we accept 2 residents each year. What's really neat is our program, unlike some of the other preventive medicine programs in the country, it's located in a health department. So it's located in the Texas State Health Department, or DSHS, in Austin. And it really makes it unique and also strategic in training physicians. Our residents train in a variety of disciplines, receiving hands-on experience in public health. So now I'd like to share the spectrum of training that they receive in tuberculosis across the following domains of clinical, research and quality improvement, and teaching. Our residents receive clinical training in diagnosis and management of tuberculosis and participate in lectures with faculty from all over, specifically TCID, Heartland Hospital, the DSHS TB programs, DSHS public health regions, and local health departments. And then they also participate in research and quality improvement initiatives. One of our current residents is writing a case report on a patient that she saw while she was rotating with TCID. And she's also completed a quality improvement project with the local health department to improve referrals and clinic flow. It was interesting earlier on today to hear about some of the challenges that counties or regions are having, and I think that those are things that are important for us all to learn going through the improvement process. Another resident is also working on a case series of patients with Hansen's disease who are treated with monthly medication regimen. And then a recent graduate who's actually featured here, Dr. Unroe, he worked with a local health department and a county jail to improve their screening process for tuberculosis during the intake at the jail, and was able to present that process at a conference. Residents also get the opportunity to share what they've learned and teach others. They've given lectures to primary care residents on screening, diagnosis, and management of TB, and they've assisted faculty in the education to healthcare providers in order to improve the referral process for patients with TB and in guidance on the management of latent TB infection. And then finally, after graduation, our residents have gone on to serve as faculty and, more importantly, continue in the care and management of patients with TB. And one of our goals is that they are confident and obviously trained to be able to do that. Some of the specific roles graduates hold are as DSHS regional medical directors, one presented earlier today, TB consultant, medical director roles at local health departments, and then clinicians that is part of their everyday role. They're screening patients for TB and managing latent TB cases. So that's all a very just brief overview of our training program, and then also some of the activities that we take part in. Thank you so much for your time, and please reach out if there are any questions or if there's an interest to participate in any of the training with our residents. Thank you.
Thank you so much, Dr. Howard, for your time as well. Someone who has worked with your alumni, I can say that it was a pleasure to get to work with them, and they have done some truly amazing things out in the field now that they're got that training under their belt. So with that being said, of course, let's go ahead and introduce our next speaker, one Benjamin Alpers. So he is going to discuss with us some of the newer testing that's being offered through the Texas DSHS lab. So welcome aboard, Ben. I see your slides.
Good morning, everyone. Happy to be here. Happy World TB Day. I see we're running behind a little, so I'll try to just get you out of here by 10:25, or maybe not quite. My name's Ben Alpers. I work with the TB reference team in the DSHS lab in Austin, and I just wanted to highlight a few updates or reminders about some of the testing we do. Just briefly, I'd like to hit on 3 topics. I'd like to talk about urine source specimen testing, WGS or whole genome sequencing, and the speciation of the MTB complex. For smear and culture testing from urine, we are not able to perform that at our lab in Austin, but the City of Houston laboratory has graciously allowed us to send all of our submitted urines to them for testing. So what this entails is that you would just send urine to us as you would sputum, And then we will just make sure that the form is clearly marked as a urine specimen. And then we'll forward that on to the City of Houston laboratory for testing. There's something to consider is that Houston cannot test a urine more than 7 days after collection. So keep that in mind while you're collecting and shipping. We can only ship out of our lab before 1 p.m. on weekdays, and we cannot ship at all on Fridays. So it's just important to keep that in mind. If you collect and ship on a Wednesday, it gets to us on Thursday, but it doesn't get to us till Thursday afternoon, then that means we can't ship till Monday morning. And even if we ship overnight, everyone knows that that sometimes weather causes delays. And if it doesn't get there promptly the next day and gets there to Houston on Wednesday, they're going to have to decline testing. So just keep that in mind. It might be best to collect urine specimens earlier in the week rather than later in the week. And we'll do our best to get that testing or get the specimen to Houston. And then when Houston reports their results, we'll attach that to your report and distribute them out. We also can perform unofficial expert testing on urine. Since it's unofficial, this means we cannot give you a printed report with the result, but we will be happy to, on request, to perform the testing. We have high confidence in the result of the testing, and then we can give you the result by email or phone. It's a very good tool for recognizing TB in urine. Now, I'd like to talk about whole genome sequencing, or WGS. This is when we sequence almost the entire genome of TB. Because so much of the genome is sequenced, we require a lot of biomass or DNA for this sort of testing. So we can only do this type of testing from culture. I'm sure a lot of you are familiar with MDDR that the CDC performs. And that's when particular genes are targeted. And there's about 15 genes that they target, and but they do not require as much genetic material. So we can send for MDDR on smear positive, expert positive specimens to the CDC for susceptibility testing. But WGS, because of the length of the genome that is sequenced, we need to have culture. That being said, once we perform WGS, we'll feed that through a pipeline that will give us some preliminary molecular susceptibilities. This pipeline looks at genes associated with isoniazid, ethambutol, rifampin, fluoroquinolone, and notoriously PZA resistance. When we started validating this test, we weren't sure how often or how many specimens we were going to test with it. But then BD recalled all of the reagents used for growth-based testing of PZA. And that was in August of 24. So that kind of forced our hand, and we brought on WGS online and perform it on every acceptable culture for susceptibility testing. That way, you can get your PZA results, and can also get some other drug results in addition to that. We also use this WGS data in a different way, and that's to compare strains to one another. We look at how similar they are, and that implies potentially relatedness and helps a lot in epidemiological investigations. This is colloquially known as genotyping. We have been performing, or genotyping has been being performed since 2004, But it's all the sequencing aspect has always been done at the state lab in Michigan, in Lansing. As of next month, we plan to take on that sequencing here in our lab, and we will submit the data to CDC, where they'll analyze it for surveillance purposes and input the results into TB GEMS. I was speaking with a colleague of ours from the CDC earlier this month, and he was very excited about this development. And he said, well, you'll once you start doing genotyping sequencing, you'll be doing more tuberculosis sequencing than any lab in the entire country. And I was proud to hear that, but also a little freaked out. That's pretty daunting, especially coming from the CDC. But I really hope the transition will be rather seamless. And I don't think as submitters, you're going to notice much difference in the process. It's possible that you may see TB GEMS populated a little sooner. I think the only instance that you're really going to see a change is for those special requests that we perform molecular susceptibilities on. I think a lot of you are familiar with the idea that you have a patient and the hospital has a contract with a commercial lab, and they send only to that laboratory, and that laboratory either doesn't perform susceptibilities or isn't performing them adequately. Now, when you contact us to ask if they have submitted an isolate to us for genotyping only, and we say, yes, we can perform some molecular susceptibilities, hopefully we'll reply saying, yes, we've already performed molecular susceptibilities. We can share the report with you. So that should really decrease turnaround time on those special cases, as long as we don't run into too many hiccups. But hopefully we'll be all right. I have confidence. And finally, I'd just like to mention that our TB complex speciation tool, we've developed a PCR tool in the laboratory that I can distinguish M. bovis and M. bovis BCG from other tuberculosis species within the complex. That we usually perform this when we receive some lineage information from genotyping, or if we see some molecular data. There's a point mutation in the pink A gene that is common to all M. bovis and M. bovis BCG. So usually we'll take it upon ourselves to perform the speciation in instances like this. We can also perform it if by special request, if we get a little background and it's sufficient to feel that this is a high likelihood for of bovis or bovis BCG. The CDC used to perform this testing, but it would take weeks, if not months, for them to do it. And now, hopefully, when we recognize an isolate, that we can get this testing performed within days. I also want to stress that this testing is done on an isolate, on a culture, much as WGS. We cannot perform this off of processed sediment. But the CDC was so happy to hear that we brought this testing on that they discontinued their testing and now refer the rest of the country to us when they need this testing. We see about, so that was thoughtful of them to recognize our lab, I suppose you could say. We see about 12 isolates or so a year from the state of Texas. And we haven't been receiving a lot from out of state, but we definitely do get some requests, and I've been performing it now for a year or two. And that about wraps up my presentation. I'll be happy to answer questions in the chat, or I feel that most of you can know how to get a hold of us if you've got questions. And yeah, enjoy the rest of the presentations today. I'm looking forward to them.
Thank you so much, Ben. I cannot stress how amazing the work that the Texas DSHS State Lab does for the TB community. It's amazing to hear that the CDC is taking notice as well, and I'm glad that you're getting your flowers from them as well as from us on this World TB Day. So thank you so much for your time. I do think that I see a couple of questions that were dropped for you about your presentation in the chat, so please feel free to go ahead and address those when you get a quick moment. But I'm going to address the group. We are going to take a quick little 5-minute break as we take a moment to really think about everything that has been shared with us in the first half of our World TB Day presentations. And then once we come back, we will go ahead and start taking a look at some of the things that are coming up or that we can do right now within our TB community. So hang tight. In the meantime, it would be of great help if everyone could just drop their name in the chat real fast, just for attendance verification purposes. So that way, when we run our report, we can make sure that everyone who has attended the meeting is eligible for their CEs. So in the meantime, enjoy the quick little recess, and we will be back at approximately 10:41. All right, everyone. I hope that we enjoyed our quick little break. We are just getting Dr. Seaworth on deck real fast. For those of you who have never had the pleasure of working or hearing from Dr. Seaworth, she is one of our 2 co-medical directors, and she is going to be discussing with us about patient-tailored treatment today. So let's go ahead and welcome on board Dr. Barbara Seaworth. I can see your screen, ma'am, and then I can hear you.
Can you just do this? Hello. Good morning. I'm going to talk to you today about new directions and an introduction to patient-tailored treatment management. And it's going to be a lot of new and different things. Many of them will seem very complex, and I'm just going to try to introduce the thought behind them. And each one of them could probably be a 10 or 20-minute presentation. So I'm just going to try to give an overview of the landscape that will be coming at us in the next few years. I have no disclosures in my objectives this morning. I rather went through them already. I'm going to try to talk about where we are now with tailoring diagnosis and treatment, and then examine some new ways to do things and some new treatment trials, and mention a couple new drugs, but we're not going to talk about specifically a bunch of new regimens. I'm going to start with treatment shortening, and I just am going to mention a couple studies. We're all well familiar with them. The Xenex trial looking at optimizing linezolid dosing. And as we move forward, I want you to focus on this. When linezolid was given at 600 milligrams for 9 weeks, the overall successful response dropped to 94 or 84% rather. And so this is why we really don't want to stop linezolid after the first 2 months when we don't have to. But notice that none of these responses are quite as good as the original BPAL study. If we look at the TB practical study, we also see only a 77% favorable response in the BPAL arm. And kind of keep these in mind as we go forward. And this is a new study you probably haven't seen yet. It's one of the NTBQ studies, and it looked at in pre-XDR TB when we can't use pretomanid, a regimen of bedaquiline, dolomanid, linezolid, and clofazimine, and it looked at it for either 6 or 9 months, depending on the extent of disease. And you can see here that when you had limited disease, it favored the experimental regimen with the bedaquiline, dolomanid, linezolid, and clofazimine. However, when you had extensive disease, it really favored the control. And the control regimen basically was made up of many of these same drugs in the experimental regimen, with a couple others added. So more drugs, and it was given for a considerably longer period of time. So when you have an extensive disease, something is happening here. And also, in addition to poor initial outcomes, there were a much higher proportion of relapses when you had the experimental regimen with extensive disease, and less so when the experimental regimen with limited disease. Down here, this little flat line, this is either the control or the experimental regimen, or the control regimen with either limited or extensive disease. You did not see the relapses. So this was a large number of drugs for a long period of time. This is what we used to do many years ago. Where we are right now, we have kind of one size fits all. The standard duration of therapy we've gone for with drug susceptible disease, INH resistant disease. Now for MDR or pre-XDR, we use the BPAL or the BPALM regimen, and standard dosing of almost all of our TB meds except for PZA and ethambutol. So we're really at one size fits all, and the TB therapy, diagnostics, and other management strategies are all going to be much more individualized in the future. And this is how we can really give each individual person what they really need to have a good outcome and to have the best treatment for them. We're going to be looking at disease phenotypes that define the extent and type of TB disease. For instance, TB meningitis really needs to be treated differently than a simple pleural effusion. We're going to look at disease endotypes, which identify the immune status and the ability of the host to respond to that TB infection, where they are immunologically at the beginning of diagnosis and treatment, and then how they respond throughout treatment. We need medication regimens tailored specifically to the extent of disease, the type of disease. We're going to look a little bit at host-directed therapies. We really don't have much time to do that. And then trying to achieve long-term health, not just a microbiological cure, is a big part of getting the best regimen for each patient. I'm going to start with something called stratified care, precision medicine. This is really a big effort of the San Francisco group led by Dr. Radha Savic, and I want to thank her for a number of the next couple slides I'm going to be using. And their aim is through this stratified care precision medicine to give the right diagnosis, the right risk stratification, whether these individuals are at low, moderate, or high risk for a poor outcome, and then the right treatment, the right combination of drugs, the right doses, and the appropriate duration for their particular treatment or their particular disease. Their goal was to, in their first study here, was to develop a risk stratification tool that would help them be able to do this. They looked at many of the older short-term regimens, in addition to study 31, which was effective with the moxifloxacin arm of the study, but many of the other short 4-month courses of therapy that had failed. And when they looked at these over 3,405 patients and developed a risk score, they were able to look at these participants and group them into low, moderate, or high risk. And they noted that the treatment duration varied depending upon which risk category they were in. For instance, with a low risk, you could get that 93% cure with only 4 months of treatment. They identified hard to treat phenotypes, and from all that, they noted that many of these 4-month regimens were really not inferior when you looked at them from this standpoint. And if you look at the risk groupings, about 23% were low risk. So 23% of people are getting too much therapy with our 6-month regimen. 48% were moderate risk, and so our 6-month regimen is just about right with the standard RIPE regimen. And then 29% are high risk, and for those individuals, 6 months of therapy probably is not enough. And this slide also looks at, for the easy to treat individuals, that any one of these 4-month regimens that had been deemed failures actually were effective, achieving 93% or nearly 93% cure. However, if you looked at a hard to treat individual, that even some of the better regimens were failed therapy. And this is just a way of looking at some of these previous studies. And you can see that across these studies, at least 76% of individuals had a favorable outcome with the 4-month regimen, up to close to 90% in a couple of the studies that were deemed ultimate failures, even though here 89% were cured with therapy. When they look more closely at these studies, especially the ones using rifapentine or using high-dose rifampin, they were able to show that in the easier to treat, these are the easier to treat, really everyone did well, no matter whether there was a low rifamycin exposure or high. But in the hard to treat group, only those with high rifamycin exposures, irrespective of the regimen, really had a good outcome. And many regimens really had very poor outcomes. Even the moxifloxacin 4-month regimen that we're using in study 31 had about 20% poor outcomes when the rifamycin exposures were low. So that's important. This is when they then went on to look at the same thing in drug-resistant clinical trials. They looked at the NICS study, the ZNICS, and the TB practical study, and they found that low-risk patients do best with either BPAL or BPALM, but higher-risk patients may need a better regimen than BPALM, and certainly more than 6 months of therapy. And here was the number portions of patients with an unfavorable proportion with an unfavorable outcome increased with baseline characteristics for risk groups, the medium risk group here and the low risk group here. And then when you added the 2-month positive culture status, you could further differentiate the low and the high risk groups. So Dr. Savage and her group went on to plan this new PRISM TB trial. I'm not sure if it's enrolling yet, but their aim was to look at eligible patients with fluoroquinolone susceptible rifampin or MDR TB and treat them either with a control regimen, the BPALM regimen for the standard 17 weeks, which is 3 months, or use the BPALM regimen and do the standard 26-week therapy for harder to treat, or for easier to treat, only a 12-week regimen, or 13-week rather. I'm sorry, this is the 3-month, and this is a standard, this is a, this is a 17-week regimen up here. So trying to identify these people as to how much they treat based on how hard their underlying TB disease is to treat. Then Dr. Savage's group is also going on to look at a predictor goal or a predictor consortium using many tools to try to identify from past failures what went wrong and to learn from them, and by doing so identify regimens that are more likely to work going forward as we plan new research trials. And they're going to use, they're looking at 3 different tools. They're using mouse models to identify easy to treat versus hard to treat patients, kind of correlating the different mice with, the cavitary lesion or someone with just subclinical disease or easy to treat disease. So this is tool number 1. The next slide, they're looking at the lesions, the particular lesions, especially granulomas and caseous lesions. You find caseum in solid granulomas that are with necrotic tissue or sometimes lining the walls of cavities. And caseum is a challenge because drugs have a difficulty getting into and staying into caseum. And what they were looking at here is the drug concentration that kills either 50% the mycobactericidal concentration or at 50% or killing 90% of the MTB in caseum. So they took infected rabbits and then excised caseous lesions and then studied in vitro studied the particular drug. And so using these, and then the last tool was evaluate the pathogen burden and health during treatment. And they're looking at that in two new ways, looking at the number of colony forming units that they see on a particular growth plate and trying to quantify the number of TB that are present at any particular point during treatment. And then using something called the RS ratio that looks at ongoing RNA synthesis as a measure of the pathogen health. So even when we may not be seeing colony forming units on a plate, we may be able to detect RNA synthesis telling us that, yes, we still have living TB lesion and some kind of quantification of that in a particular individual. So they applied these three tools to a recent trial that was really disappointing, that was failed before they could even get to stage 2. They were doing 3 different arms with 4 months of each arm, and they were substituting either dolominid or pretominid in, along with bedaquiline, and then 2 new drugs. And so that's why it's called XBQU. So the X is either dolominid or pretominid. Then everybody got bedaquiline, and everybody got this new drug, which is called, from a group of drugs called DRIP inhibitors. And there was a lot of excitement about these drugs initially, and that's the Q. It's for quabodepastat. It's I'm not sure I said that right, but I think so. The Q, and then cystazolid, which is a newer linazolid type of drug. So everybody got the Q and the U and the B, but the X might be different. And they had 4 arms of each of these. And then arm 3 was the standard rape regimen. So using these tools, when they looked at, do we have a hard to treat patient population, they found that 61% of the individuals that were in the modified intention to treat group actually had very challenging or hard to treat disease. So this was going to skew toward a treatment regimen that failed. Many had radiographically advanced disease, bilateral cavitation, and then very high smear grades. They also looked at how well do these particular drugs in this XBQU regimen get into a lesion. And one of the drugs they were comparing, or one of the regimens they were comparing it against, was one that we can't use, although it's probably one of our best regimens, but we rarely, if ever, use it because of the hepatotoxicity when we add pyrazinamide to bedaquiline, pretominid, and moxifloxacin. This is a really powerful regimen, but there's a lot of hepatotoxicity. When you do a 2-drug substitution, substituting moxi and PZA and putting in the quabodepastat and the cystazolid, they got what they thought was going to be a very helpful new regimen. But probably because of higher lesion liability, this didn't work. And let me show you what I mean here. If we look at these drugs with high ability to penetrate into caseum, moxifloxacin is way up here on top. One of the metabolites of bedaquiline, cystazolid, bedaquiline itself, and then pretominid, PZA, and quabodepastat is way down here on the bottom, really doesn't get into the lesion at all in any meaningful way. And this is another way of looking at that lesion coverage. And you can see here bedaquiline, it's in there at levels which would achieve a minimum bactericidal concentration of 90 or kill 90% of the organisms. Pretominid only gets in there at 50 at the MBC 50. Cystazolid is in for a couple hours at the MBC 50, and quabodepastat has no activity. So really, this new regimen probably failed largely because of the inability to enter the caesium, as well as very hard to treat patients. And then just, okay, then moving to where else are we going? What else do we have to look at? We're looking at replacing perhaps bedaquiline regimens with a new bedaquiline type of drug called surfecolin, or S. And this has now been studied in a phase 2 study, and now is being moving into phase 3 and hopefully to registration or compassionate use relatively soon. The TB Alliance is really working hard on this new bedaquiline type of drug. They're also looking at 1 month oral long-acting injectable regimens after 30 days of an oral regimen, giving a single injection. And this is a ways off, because when you talk to the people that are doing the long-acting injectable regimens right now, or compounds, they haven't been able to put more than 2 or more than 1 into any particular injection. So they're hoping, though, to get to a single injection so individuals don't have to have multiple injections. But this would be rather amazing if you could get oral meds for 30 days and then a single injection that would be therapeutic for 3+ months. And that would be your TB regimen. And then these are some of the drugs they're looking at for long-acting injectable regimens going forward. So we're maximizing treatment shortening with drugs, disease phenotypes, regimens, but cure of TB disease does not always equal health. And so we need to look at some of these phenotypes, hard to treat, different drug regimens. We need to look at the underlying host immune defense and response, or the endotype, and try to see if we can target that immune response to improve the immune response as well. And this is a nice article by Dr. DiNardo that all of us here in Texas know, but looking at understanding the patient's endotype will likely allow specific host-developed therapies that can be targeted to the patient's specific immune response. We're not there yet. We're a long ways away from doing that. We have to gather a lot of data to identify those endotypes and then try to begin to manage some response or treatment for them. Right now, there's no single immune correlate of protection that has been identified, and what could be beneficial for some patients might be harmful for another. That someone might be deficient in TNF alpha or gamma, or just right, or they may have too much, leading to necrosis. So survival is over here deficient. A lot of hyper activity and necrosis, and this is the Irish type of phenomena. This is just too much immune response, and where we're aiming for is right here, just right, and we're nowhere close to identifying that yet. But the more we learn, the better we'll be able to be at this. In addition, looking at maybe new ways to diagnose TB. Biomarkers may be able to assist us with earlier diagnosis, but they're not ready for prime time yet. But up to about 50% of disease may actually be subclinical in many groups, especially when you're doing case finding. And we don't have a good way to identify these individuals yet, because usually they're culture negative or only intermittently positive. Smears are negative. They are sporadically infectious. They don't have symptoms, and we really need to find and treat those individuals. This was a nice study that was from a nested study within an active TB case finding study in Vietnam. And they looked at individuals with TB disease, LTBI, or controls. Mostly these people were asymptomatic or had only 1 mild symptom. Then they screened them with a 9-protein panel. And they found that 2 of the proteins that they used IP10 and IL-6 were both significantly elevated in individuals with clinical TB, with a specificity of 95.5%. Now, it wasn't very sensitive. They only picked up about a third of the individuals with TB in this particular study, but it suggests that measurable changes are happening at the transcriptional level in those with early TB disease and are associated with an inflammatory response that we're seeing in TB disease, but not latent TB infection. So we just need to get better at identifying these protein panels and which ones we can use. Another author looked at a 7-panel protein panel and was able to get a sensitivity that was up to close to 63%, I believe, and maintaining that specificity. But if we get to the point where we have a patient, we think that this is subclinical disease, this isn't plain old LTBI, those are the scariest patients in our clinic. We don't want to treat any of these people with percolating disease with a single drug and get drug resistance. If we were able to test IP10 or IL-6 and it was very elevated, this might tip us over to wanting to identify this person as TB disease. And so we're going to be able to get some of these tests to help us with identifying those subclinical diseases in the near future. And I think I'm going to end with this because I'm probably going over, but post-tuberculous lung disease is something that's impacting up to 50% of the individuals that we treat with TB. These individuals are left not well. We cure their TB. Oh, Alicia just tells me I have 5 minutes left. Might have a few. We cure their TB, but they're still sick. They're still coughing. If you measure their arm circumference, they're thinner. They have more cough at night. They have more trouble gaining weight. They have more shortness of breath, and they have more difficulty with ongoing lung infections. So they found that in this study that they looked 6 months after completion of a 6-month treatment regimen, and they defined abnormal spirometry at that 12-month point as being post-tuberculous lung disease. They found that it was more common in those who had prior TB, and as I noted, these individuals had more cough, more dyspnea. They noted that it wasn't the same, and actually another group has gone on to identify 5 different types of post-tuberculous lung disease. But this particular study here only looked at either restrictive lung disease, in which the forced vital capacity is low, or obstructive, that the lungs are larger, but you have difficulty breathing out. So about 29% had the restrictive variety and 21% had the obstructive variety. But what was really interesting, I think, is that if you looked at these individuals, those with restrictive post-tuberculous lung disease, if you looked at differential gene expression early on, you could notice early inflammation and immune activation, and this resolved by the time treatment was completed. However, those with obstructive post-tuberculous lung disease didn't seem to have a differential ability to identify them with a gene expression at the time of diagnosis, at least not yet from what they were looking at. But as treatment went on, they had ongoing inflammation, and at the end of therapy, they actually had differential gene expression at the 6-month visit. So there are different types. Not all post-tuberculous lung disease is the same, and it probably needs to be managed differently. And it also needs to, we maybe can identify it at the beginning, at least some of the types, and work to try to prevent its development. The only 2 recommended host-directed therapies in TB right now are antiretroviral therapy in HIV TB, and then adjuvant steroid therapy for TB meningitis. These are formally recommended regimens. So, but I think in the future, we will be seeing more. The TB Alliance, which is a major research group, one of their main goals moving forward, in addition to shortening therapy and getting long-acting injectable therapy, is to identify host-directed therapies, because the bugs are always going to have be able to figure out something with new drugs. But if we can enhance the host's immune system, we may be able to really shorten therapy and have more effective therapy and end up with a patient that not only has a bacteriological cure, but is well at the end of therapy. And some of the strategies they're looking at are targeting the inflammatory mediators, disrupting the granuloma. Remember, I talked about lesion penetration of the drugs? Well, they're looking at how do we disrupt the granulomas so we don't have to worry about a drug like quabadepostat that can't get into the lesion, to enhance macrophages, to kill the MTB, and then enhance the immune response. So this is a really new direction that TB Alliance has taken. And remember, they're the ones that gave us BPAL. So they are not afraid to dream big, to be bold, and to be very aggressive in going after new ways to take care of our TB patients. And sometimes they fail, but they really keep at it. And so this is their big plan. This is their roadmap to the next transformational treatment paradigms. And I also already mentioned that Sofequelin replacing bedaquiline, this 1 month oral regimen with followed by a single injection, and then looking at getting all of these drugs as long-acting injectable therapies. So I think I'm going to end there. There are some other ways that people have looked at to maybe do host-directed therapies. Those are non-specific. They involve things like metformin, maybe adding ibuprofen. And with both of those, you don't really get to cure any more quickly, but you can decrease mortality in a few of the studies, or decrease, there seems to be a general decrease in lung inflammation with both the use of metformin or ibuprofen. So we have a long ways to go in trying to deal with the immune response but I think it's really exciting time to be in TB. It may be way harder for us in Texas to write the SDOs because treatment is going to be more complicated. Our forms and our histories and our evaluations may take longer, but I think patients are going to do well and really benefit. So thank you.
Thank you so much for sharing, Dr. Seaworth. I mean, guys, I cannot emphasize enough just how much documentation Dr. Seaworth goes over. Documentation that makes me cross-eyed, like just looking at it, and how she breaks it down so easily and so eloquently. So thank you so much for your time and for sharing that information with us about what's to come on the horizon, Dr. Seaworth. Now, let's go ahead and pivot over to a trio of fabulous ladies. I'm going to bring up to the stand of sorts, Dr. Lisa Armitage, who is our other co-medical director here at Heartland National TB Center. But she is going to be joined by Catherine Yo, who works as an epidemiologist at the Texas Department of State Health Services, as well as Lee Riggins, who was our basically our field reporter in regards to this particular presentation. So ladies, welcome aboard. I can see your screen. I'm only seeing the editor mode, but that's perfectly fine. And whenever you ladies are ready.
All right, good morning. This is Dr. Armitage. I wanted to welcome everybody to our World TB Day. I'm going to kick off the session on TB in pediatric populations. We're going to pivot a little bit to something different, and I'm going to start us off, and then I'm going to get out of the way because Lee and Catherine have some excellent information for us. Next slide, please. So the first thing is, a lot of times pediatric TB kind of gets left off because we're just that little purple bar and the little mauve bar. down at the bottom of the the spread on age. But let's go to the next slide and see what those little bars are doing. So we kind of nadered down in 2021, in 2020. Everybody's numbers went down. We kind of took our eyes off the prize and started focusing on COVID. But if you look at, we're about 4% of, in 2021, we're about 4% of the cases of TB. So 0 to 4, but as a little bit more, like, Sandra pointed out in her presentation, and 5 to 14, about the same number. But when you look at 2025, and I want to give a shout out to the CDC for throwing the data out yesterday, just threw it in. So fresh off the presses, we're still at about 2%, but 0 to 4 years of age has increased to 3% of cases. So now we've gone from 4 to 5% of cases. But if you look, there's like 100 new cases in each category of kids. So we have 200 new kids in 2025 compared to just 4 years ago. 200 across the board, but that extra 100 in the 0 to 4, especially concerning. Next slide. So if you look at when you're infected, so if you become infected with TB in your first year of life, so between birth and 1 year, you have almost a 50% chance that you will progress to active disease. If you are infected between 1 and 5 years old, you have a 24%, almost 1 in 4 chance that you're going to develop active disease. So compare that to healthy adults that are, only 5 to 10% over their entire lifetime. You're lapping that several times if you're infected when you're young. So these are our category of kids that we're most concerned about. And that rivals patients with HIV who have an immune system that's under attack by a virus. Next slide. So one of the problems with one of the biggest problems is that we say common symptoms of TB disease in children, very common for a lot of other things, cough and respiratory distress. So all you have to do is take one child and send them to daycare for the first time, and then we will run through all of them. Their pulmonary findings on exam, same, little noses rattling, chest rattling, lymphadenopathy or lymphadenitis. Unfortunately, some signs and symptoms of meningitis, the most scary part, that's where we usually end up finding them a lot of times. But we want to get to them faster. So how do we do that? But again, things like persistent fevers, fever of unknown origin, weight loss, or failure to thrive. But the last bullet is the most important. Up to 50% of children with TB disease have absolutely no symptoms. Next slide. So in addition, unique kind of challenges other than being more difficult to diagnose and these non-specific signs and symptoms, there are just fewer bugs. And so me and the EPIs get into it because my thought as a pediatrician is he who pokes the fewest holes and gets the right answer wins. So culture is a lot of times, if we have a source case right there with the kid, then we're a lot of times not as motivated to try to stick needles in places or swabs in nose. I would love to just go to my 2-year-old and say, hey, little dude, can you just hock up a loogie for me and throw it in the cup? And that would be fabulous. But even if I could train him to do that, the chances are there's just not many bugs in there. But there's a high risk of increase of progression to disease. This is a high risk population. So higher risk of extrapulmonary and TB disease and TB meningitis, which is hard to treat and difficult and scary once you diagnose it. Next slide. Very important. The percent of cases, this is out from the CDC data, percent of cases attributed to recent transmission by age group. Look at the 0 to 4, 60%. I'm just going to say that other 40% is just something they didn't find. These are sentinel events. This kid, they don't get infected and kind of drag things out for years and years. If you have TB at 0 to 4, somebody in your immediate, in your immediate space, has TB. So if we diagnose the child first, we're doing a source case investigation, but that only drops to 40% once the kid gets older and starts going to school and having kind of other outside activities. So when you have a child who has disease, this is the hint as to where we're going to get to these babies. Next slide. And this one of the most important things that we've learned, and this is the last slide before I hand it over and we start talking about what we're finding in Texas and ways to get about this. U.S. studies, this is out of the CDC guidance. 1 in 5 to 1 in 10 of childhood TB cases can be prevented if you just treat children who are exposed in a household to an active a source case with active pulmonary disease. If you just treat the ones who are exposed, children who should be considered for treatment after exposure, household contacts of a contagious person, they have an initial TST or IGRA negative in the window period for conversion, and then a CDC and a chest X-ray and physical exam normal. So we're saying window prophylaxis recommended for children under 5. You saw the higher risk of disease. In immune suppressed patients on TNF alpha blockers, and then also the most important thing is it can prevent progression to disease during the window period. And the most important thing on this slide is we're talking about preventing something before it happens, but you have to find those kids. Next slide. So I want to take a minute before we move forward and just give a shout out for it says on this is my feeling. Thank you for your attention today, but thank you for everything you do to watch over our little ones every single day. And I want to give a shout out to our CIs, the CIs who are going in the house, and when people tell you that there are no kids and you see the toys and you're calling out, and baby bottles in the the drain. For the clinic nurses, Jackie still have one kid, came in, everybody in the house is having that little bark from postnasal drip. She did not like this one kid, and actually he gave up a bug for her. The physicians, the pediatricians who are trying to take care of our little ones ahead of time. But I wanted to especially shout out to our DOT workers who are out there running the rules of negotiation with toddlers and those medications every day, and how important the things that you do are. And then I'm going to pass it off to Lee, who is going to take us to the next level of actually how it's impacting what we do.
Thank you, Dr. Armitage. Good morning and happy World TB Day to everyone. Thank you for all you do, everybody's discipline and action in TB. You understand that not one of us could do it on our own. We all need each other to tackle the problem and hopefully one day end TB. All right, so we'll go right into it with a source case I have to present. This started off with identification. It was a grandfather that lived in the home, 56-year-old male, came to the United States from Mexico in the year 2000, but he'd had a brief stint of living in California also. Medical history was remarkable for alcohol abuse. In June of 2025, identified as a person with suspected TB while he was in the hospital. The IGRA was positive, and he was positive for TB symptoms that started the differential workup. Sputum was AFB positive, ultimately MTB positive on the NAT and culture, and turned out to be pan-susceptible. Radiology presentation, cavitary lesions in upper lobes bilaterally. Symptoms he presented with was cough, weight loss, and malaise for about 3 months before diagnosis. We started this patient off with RIPE therapy. Unfortunately, there was a tolerance issue, a lot of nausea, vomiting, couldn't retain the medication. So there was a brief hospitalization for IV treatment. Once that was started to roll, he started tolerating meds well and should complete his therapy in April of 2026. So what did the house look like? So looking at the environment, it was about a 2,000 square foot mobile home. Poor ventilation was noted. There was very little furniture in the home. Actually, the only furniture in the house was a couple of mattresses in each of the bedrooms. There was no furniture otherwise than that. So there was a strong smell of marijuana on most days that our staff was able to respond to the home, and all the smoke detectors in the home were covered. Household composition, of course, the 56-year-old grandfather diagnosed TB disease and started RIPE therapy for 9 months. There was also his 29-year-old son, TB infected, ATS class 2, no disease. This individual declined therapy. 27-year-old daughter-in-law, TB infection, ATS class 2, also declined therapy. 4-year-old grandson, diagnosed TB disease, ATS class 3, and then there was also a 3-year-old grandson, both TB disease, ATS class 3, and it was a long road ahead trying to convince parents even the need for assessment, helping us diagnose and get where we are with them. There was also a 24-year-old son, TB infected, ATS class 2, and that individual did complete LTBI therapy. And then 21-year-old son with diagnosed TB disease, ATS class 3. This individual was smeared negative, but the final culture was MTB positive, non-cavitary chest X-ray, and was treated with RIPE for 6 months. This was a presentation of the 2 grandchildren. Both were asymptomatic, normal weight, normal appearance, normal behavior to appointment, and we'll get into that in a moment. Positive IGRA, both chest X-rays, perihilar interstitial infiltrates with peribronchial cuffing, and then the 4-year-old did have a CT where there was nodular presentation in the right upper lobe, and then some lymph nodes were enlarged. So radiology is how we initially diagnosed and started the ball rolling trying to get these kiddos treated. To say it's been a rough road is definitely a blanket term. We initially started on RIPE therapy with the plan for 6 months, and after consulting with Heartland, we would change the Shine therapy. Some challenges we encountered. So that first off, there was inconsistent adherence to basic hygiene, clothing. These children, most of the time when encountered at their home, were unclothed or very minimally clothed. Significant eating patterns with children. Primarily, these children did not have normal eating times. The family practiced a grazing type method, so all food was kept at waist level, at adult waist level, so in reach for them, and they were allowed to eat pretty much whatever they elected to eat at the time. So there was no hunger drives were off, so we couldn't really catch them at a time to make sure to entice them with whatever we mixed their medications in. Significant social isolation. There was little to no history of school attendance or any kind of community, involvement. They didn't have friends that come over, and they didn't have a lot of family interaction. These children were very isolated at the home. And then there was also the active resistance to care, which we can assume would happen with a 3- and 4-year-old. That's why we work our magic, right? We have our tricks and we have our ways. But this became it was very evident very quickly that those weren't going to work. We had to really pivot consistently. There was physical aggression during the attempts for med administration. And then a lot of times, we would work, as we all do with the families that we're working with. Okay, if you can't meet me, I'll meet you. What time? And then we would get there and they wouldn't be there. So lots of challenges that we encountered with this. So really what we did immediately, we involved our social worker team here in Region 4-5 and definitely asked them for assistance. There were multiple disciplines that elected to involve CPS with the care for this family. And after that involvement, parenting classes were recommended for these parents and the family. The social work team also assisted with helping the family apply for Medicaid and other social programs that could assist them in their needs. And that definitely helped adhere to safety changes that we'd witnessed in the home. Heartland has been involved very early with this, with changes in the medication and any suggestions and help that we've asked for them right off the bat. And we got really interesting. Public 4-5's nursing team, their community health nurse team, and their support team are awesome. They did some amazing things. We of course tried compounded medication from the state pharmacy, but as a lot of us know, that sometimes that's a lot of milliliters to try to administer. So we went to trying to do drinks, all kinds of, and I'm a big firm believer after 13, 14 years in TB, Hawaiian Punch is the first one I think of, but we tried a lot of things. ice cream, pudding, Nutella. And then we got kind of innovative, and our nursing team here in 4-5 thought about making, they would give the children a treat when they would come to medicate the grandfather. They would give them a piece of chocolate. In other words, trying to enforce it's a positive interaction. Yes, we have to be in your home, and here's a piece of chocolate. So we had to really work with the pharmacy and make sure on temperature wise how we could temper chocolate and get the medication in there. And that worked for a few times. It actually did. So our plan right now, we're still trying. We're still trying. So we initially attempted treatment in July of 2025. One attempt was successful in breakfast sandwiches for both of them. And between the two of them, between 4 to 5 attempts have been successful with the tempered chocolate, and then that no longer is working. We are continuing to closely monitor these children for disease progression with regular visits with regional medical director and our social work team. Heartland is updated every couple of weeks for these kiddos. We're watching them and still trying everything we can. We weigh them weekly, symptom check weekly, and we get regular chest x-rays and assessments. Again, we consistently communicate with Heartland and provide them updates, and we just keep trying. A little puzzle piece dropped in September of last year. We received a notification from the TB section that the grandfather's genotype matched that of a 2023 4-5 patient. The 2023 patient shared the same surname as our 2025 patient. Unfortunately, the 2023 patient died while he was in intensive care, but it was shortly after he had provided some information to our contact investigation team. The contact investigation in 2023 rendered 4 contacts. All 4 were tested then. And none of the 2025 group that we're dealing with currently were named in that contact investigation. In 2023, all 4 tested, 3 were negative ×2 on their IGRA, and 1 was a borderline IGRA that ended up being a loss to follow-up. Currently, our source case continues to deny knowing anyone with TB, anyone he may have been exposed to, anyone in his family that had illness. So we just keep going. Considerations. We all know that pediatric care, you have to pivot, you have to change, you almost have sometimes the double work. So allowing some tips for success, extra time for during assessments and your DOT visits. Double the communication. So not only are you going to have to explain the rationale in a sense to your patient, depending on their age and how they're going to take that information, but you also have to educate the guardians and the parents. Interact with your patient on their level, be it age appropriate or comprehension-based communication skills. And sometimes those don't match. Sometimes the age and the comprehension level is not the same as you would think. So you do have to kind of look at who you're talking to and how they're going to receive that information. And provide for a calm or somewhat most conducive to what you need to do environment. Definitely focusing on trying to decrease that fear for the kiddo. So potential challenges, I'm sure we've all kind of heard these kind of things. Strangers are scary. Who is this person? Why are they coming to my house? Why am I having to go to this clinic? So gaining that trust of the child early on, especially, and the parents and the guardian, is paramount. And using consistent staff. Seeing the same person, the kiddo gets used to one person or a couple people, will usually give you a better outcome. But hey, I'm not sick. Why are you giving me medicine? That's what a kiddo may say to you. The child may be asymptomatic at the time of diagnosis, kind of like what we're dealing with here. Or they may have LTBI and you're having to give the kiddo their medicine. So they would be, they don't have symptoms. So provide the child and guardian rationale as to why you're having to assess them, why you're having to treat. Hey, but this medicine tastes funny. Try to use those food, drink products that help mask the taste of that medicine. You do also have the compounded medication from the pharmacy. Whatever they'll take, go with it. May offer incentives or rewards for cooperation, but before you do that, make sure parents are okay with it, because you just got to make sure boundaries are respected and rules are respected when you're there. But I'm all better now. Why am I having to still take medication? So especially for your kiddos that were really sick and then they start to get that medicine and they pop back up, make sure parents and kiddo know, yeah, we're still going to take this medicine. We're still going on, and ensure they understand the continuity of care need. So here is a list. This was a golden list that we received from Heartland when we first started. Again, we're still trying to pivot and find something, but all of these items I would definitely suggest if you start having some difficulty in identifying what a kiddo may want with their medication. These are all good ideas. All of them were tried in 6-5. And again, with that tempered chocolate. So yeah, thanks so much for letting me share. And I'll get this up over to Catherine.
Thank you so much, Catherine. And thank you to all of our wonderful ladies for showing us just how complex and tricky and important dealing with TB is within our little population throughout the state of Texas. And so it's so nice to reintroduce Dr. Armitage back for our next talk, but also she's going to be partnering with another really important member of our DSHS team, Rachel Munoz, where they are going to talk with us about some of the stuff that has been happening as far as piloting a new short course regimen. So ladies, whenever y'all are ready, feel free to take it away.
All right, back misbehaving on a webinar near you. We're talking about the 4-month treatment regimen. So we got all excited. You know, we're gonna get out there and we're gonna pilot the 4-month regimen. I think Rachel will talk about it. We had, I think, 3 different. I think we were short of every drug in the regimen at least one time. But next slide, Rachel. So just a reminder, this is the study that if you ever wanted to look it up, you know, we'll have the slides available, but it were 2,234 participants. What I liked about the study, only about 10% of them were persons living with HIV, but most of them had cavities on chest x-rays. So Dr. Seaworth talked a lot about easy to treat and harder to treat patients. And so most of our patients are going to have significant disease, but they also have diabetes. They have, you know, like other underlying problems. So we wanted something that was a little bit more representative of what you're more likely to see. There are actually 3 arms in the study, and this is a non-inferiority study. So they weren't looking for something superior to RIPE. So this slide just shows that the control was the 2 months of INH, rifampin, PZA, ethambutol, so 2 months of RIPE, and then 4 months of INH and rifampin. The second one just swapped out rifapentine for rifampin, and the third arm actually switched out rifapentine for rifampin, and then to the sisters of the week, ethambutol, and switched it out for something with a little bit more teeth, and that was moxifloxacin. So now we have, you know, a regimen that, you know, the more kind of intensive regimen. Just some notes at the bottom, RIPE was done at the standard doses, wasn't anything fancy. It was dosed daily, 7 days a week. At least 5 days were observed. Rifapentine was 1,200 milligrams for every participant, and moxifloxacin was 400 milligrams. Next slide. So there was the rifapentine moxifloxacin regimen was allowed, both regimens were allowed a 6.6, you know, point difference. So as long as they were less than 6.6% worse, then they were going to be considered okay. So I asked about this 6.6% in several venues, and I get a lot of mumbling. And then finally, one guy just said, I don't really understand what that is. But some very smart people sat in a room and decided that was the cut point. So as long as you were less than that, then that was considered non-inferior. So obviously, you would have to be shifted over to the other side of the 0 line for it to be considered better. But for the most part, you know, it was within the range. When you just replace rifampin with rifapentine, not so much. That one was an inferior regimen, so that got booted off the island. Next. And the next slide, Rachel. Here we go. So important, the study was safe and efficacious. That's, you know, what we see is the efficacy, favorable outcomes was about 90% in the control, 90% in the rifapentine moxifloxacin arm. When you go to safety data, about 19.3% of people had grade 3 or higher adverse effects, and it was a little bit less with the rifapentine moxi regimen, but essentially the same. So all-cause mortality, same. High, you know, the higher levels of adverse events, same. Favorable outcomes, same. And just at the bottom of the slide, they broke it down for patients with and without HIV. and pretty much everything stacked up about the same. Okay, next slide. So some potential challenges we knew going into the pilot, pill burden. So you get one isoniazid capsule, the little white football shaped thing that's not really tiny, 8 rifapentine, 1 moxifloxacin, and 1 B6. Everybody got that. So that's 11 pills that you got. Everybody got off the top. And then PZA was dose for weight. So you got either two to anywhere from 2 to 4 additional pills. Tolerability was our question. So we know that, it was safe and we know it was effective, but the question is, what was the tolerability? Second thing is familiarity with the regimen. What if somebody can't tolerate moxifloxacin? Can we switch out levofloxacin? There's no studies with that. There's no guidance on substituting any of the drugs. If they have renal failure, there's no studies about can you make PZA, 3 times a week instead. And when you get to the end of the treatment, and they need more treatment. So we've been there. You get to the end of 6 months and you look at that chest x-ray and that cavity is closing nicely, but not closed. So now, there's no real guidance on how long, if you're going to extend treatment, which makes sense. If they need more time, you give them more time, but how long more time? And then the biggest thing was the drug shortages. So now after this, I think that was my last slide. I'm going to hand it over to Rachel to talk about what we actually found when we did it.
Thank you so much, Dr. Armitage and Rachel. It's so exciting to hear that the state is really looking forward to implementing a new regimen within the statewide system, and that so many people are enthusiastic about taking it on. So next, let's go ahead and pivot. Rachel, you stay put because you're tag teaming now with one of our HNTC nurses, Catalina Navarro, and you guys are going to discuss how drug resistance as well as the binational program. So whenever you ladies are ready, please feel free to go ahead, start sharing screens, turning on mics.
All right, let me take a drink of water. All right, thank you very much. All right, so here I am, me again. So I'm going to now pivot a little bit to the landscape of drug resistance in Texas and what's on the horizon. Our objectives for this presentation is to describe the epidemiology of drug-resistant TB in Texas and along the Texas-Mexico border, identify those components of managing drug-resistant TB to prevent emerging resistance, and outline how to diagnose drug-resistant TB and the care associated with it. And as Lauren mentioned, I'm joined today by Catalina from Heartland National TB Center, who will discuss the collaboration and the support provided to the binational TB programs. So let's get started by reviewing some epidemiology. It would not be World TB Day if I didn't start by discussing the impact of drug-resistant TB in the world. Even though the numbers of MDR and rifampin-resistant TB have steadily been falling since 2015, the emergence of drug resistance is found in every country, and per the CDC in 2023, 400,000 people developed rifampin-resistant or multi-drug resistant TB globally. Of those, only 68% who started treatment were successfully treated, and approximately 150,000 individuals succumbed to this disease. Despite the decline in general drug-resistant TB, extensively drug-resistant TB has now emerged in over 100 countries, posing a significant threat to eliminating TB in the United States and across the world. With this new report, Texas faces rising risk, particularly considering that, as Sandra mentioned, over 60% of our TB patients are non-US born. This graph here represents the number of MDR cases from 1994 to 2024. In 2024, 115 cases of MDR TB were reported by the CDC in the United States. The purple bar, the smaller bar here, indicates those with previous TB disease, also known as secondary or acquired disease, which are likely acquired by either inappropriate regimens or poor adherence to therapy. The green bar indicates those with no prior disease, or we often call it primary disease, suggesting that drug-resistant strains are being transmitted person to person. The gold line represents individuals with TB in the U.S. with no prior history of TB disease. And as you can see, fewer than 2% were identified with MDR TB since 1995. Now, we also see drug-resistant TB in Texas, and this graph here shows the number of drug-resistant TB cases from 2022 to 2025. In our drug-resistant monitoring program, we closely monitor patients with rifampin resistance or higher, and that's what's indicated on this bar here. The rifampin resistant is represented by the red-orange bar, MDR by the green bar, pre-XDR by the purple bar, and XDR by the blue bar. Rifampin resistant and MDR, as you can see, were the most of our drug resistant, as indicated by those red bars and the green bar. In 2024, this was our biggest year for drug-resistant TB since COVID, where we did have about 14 cases of MDR, 10 of rifampin resistance, and 2 pre-XDR patients. Luckily, we did not have any XDR patients reported in 2024. But what I do want to point out on this graph is while XDR TB is not new in Texas, and we had a patient reported in 2022, in 2025, we had an XDR patient, but this was our first patient that fell under that new definition of XDR TB, where the patient had mutations to drugs in the BPOM regimen that really compromised the efficacy to be able to use any of those drugs in that regimen. What I want to show on this graph is like the national average where primary disease is reported more than secondary disease. The same holds true for Texas. So as you can see here, represented in the blue bar, these are our primary disease patients, and these, the ones in the orange are our secondary disease patients. So with primary disease, really letting us know that drug-resistant TB is also being transmitted person to person in Texas. Not only do we see drug-resistant TB in Texas, but also along the Texas-Mexico border. Texas shares the longest border with Mexico than any other state that spans about 1,200 miles, and millions of individuals cross into Texas every year. Sandra spoke earlier about the rate of TB along the border. Our binational TB programs really serve patients along this border to reduce the rate of transmission of TB. We have 4 binational TB programs that collaborate really closely with physicians and nurses in Mexico at 6 clinics to provide that direct patient care to our eligible patients. Our first program is the Juntos program that is located in the border of El Paso that serves patients in the city of Ciudad Juarez that is located in Region 10. Next, we have our Esperanza y Amistad program in Region 8, and that serves patients in two cities in Mexico, Acuña and Piedras Negras. Then we have Los Dos Laredos program in Region 11 that serves patients in Nuevo Laredo. And then finally, our Grupo de Sin Fronteras program that serves also 2 clinics, one in Reynosa and one in Matamoros. So these clinics in Mexico, mainly the ones along the Reynosa and Matamoros, account for as much drug-resistant TB, if not more, than compared to Texas. But Catalina will later go over the hard work being done in these clinics to ensure that drug-resistant TB is being treated and managed under the standards of care. Now, Texas is the second highest incidence state for TB in the nation, so there's a lot to talk about in our approach for combating emerging drug-resistant TB. But let's first start by talking about how do we diagnose drug-resistant TB. Ben touched a little bit on this earlier. Now, the first step in addressing emerging resistance of drug resistance is to identify it early. Our laboratory provides that gene expert, which can identify mutations associated with rifampin resistance that can result in about 24 to 48 hours, really hoping our TB programs coordinate care early. As soon as there is an MTB culture, the lab sets up for drug susceptibility testing to include fluoroquinolones, and in about 11 to 14 days after a positive culture, they're able to report if there's any resistance to INH or rifampin. Now, once that expert hits on a rifampin resistance, our laboratory will reflexively send an adequate sample to the CDC for molecular testing using that MDDR test. And since 2023, the CDC has used targeted next generation sequencing that identifies resistance to bedaquiline, clofazimine, and linezolid, or mutations, I should say, which really help identify emerging resistance sooner. Now, the results do take a little bit longer, about 7 to 10 days, but these results were not available to us prior to 2023. And as Ben mentioned earlier, in late July of 2024, the lab began performing those whole genome sequencing on cultures for first-line drugs, including PZA and fluoroquinolones, providing that faster result than traditional cultures. And many times we do receive these results faster than the MDDR from the CDC. And also, Ben mentioned that in April, they'll begin doing those genotyping that were previously done out of state, hopefully increasing the turnaround time for these results. Bedaquiline is a key drug for the treatment of MDR rifampin-resistant tuberculosis and was the first new drug for the treatment of MDR TB in over 40 years when it was first approved in 2012, which really transformed the management of drug-resistant TB. Also, with the new molecular testing capacities, we can now test drugs that we previously couldn't. However, recent studies have reported the emergence of bedaquiline resistance. And in a meta-analysis article in May of 2025, it showed that 10% of MDR cases in South Africa now have bedaquiline resistance. And the CDC has also noted other cases within our nation of TB that also showed mutations associated to bedaquiline. And as I mentioned earlier, Texas now reported its first case in 2025. A major challenge in managing drug-resistant TB is the limited knowledge of bedaquiline resistance mechanisms that are really compounded by discordant phenotypic and molecular diagnostic results that really underscore the need to better understand the mutations that are associated with these resistance. We face many challenges when managing drug-resistant tuberculosis, and while we do have good diagnostics in place right now, we recognize that there's a need for faster diagnostics and DSTs that don't currently exist. Like, we don't have drug susceptibility testing for bedaquiline. We're also very lucky to have a centralized laboratory that alerts us really quickly when resistance is identified and coordinates that routine specialized testing needed for further testing. However, there is a lack of standardized procedures and at external laboratories and bottlenecks that prevent consistent submission of viable samples to DSHS. And then we're followed by the variations in reporting, often requiring specialized knowledge to help us interpret those results. Dr. Seaworth highlighted the importance of building an effective regimen as it is key in the management of drug-resistant TB. And while BPOM really is an effective regimen, having access to all the medications can sometimes delay starting patients on this regimen. Some medications are very costly. Bedaquiline is about $25,000. So really applying for patient assistance programs helps offset those costs. However, this process is time consuming for our nurses and our providers. Our XDR patient also recently required a medication called Tadazolid. I hope I said that right, which is off-label and is very expensive. That medication is costing about $13,000 a month. There's also drugs that are not available at our pharmacy because they require either an IRB or are no longer being manufactured in the United States. DSHS does hold an IRB for clofazimine, but here recently our partners at TCID worked with the Global Drug Facility to acquire 2 drugs that are no longer available, PAS and ethionamide, to be able to procure these medications from that facility, noting that this was the first time ever that the United States had been able to secure medications from the Global Drug Facility. And also maintain an effective regimen. To maintain that effective regimen, patients may often require medication adjustments to ensure they're receiving therapeutic doses of these medications. Managing toxicity assessments and monitoring labs also may require a learning curve, as not everyone who may have managed drug-resistant TB in the past, especially programs that need to provide assessments like peripheral neuropathy in the field, which may require a whole different skill set. Because monthly ECGs are also required for patients on bedaquiline. Not all locations have the equipment, so clinics are partnering with private providers or FQHCs to really ensure that necessary toxicity monitoring is occurring. And in addition, mastering the nuances of therapeutic drug monitoring really does require precise sampling times, and may be difficult to manage and which may directly impact dosing adjustments if not done correctly. Finally, providing patient-centered care is a significant challenge, and nurses are a critical component in managing emerging drug resistance. They must learn to manage side effects that may be associated with the medications and implement interventions to minimize patient discomforts and to promote treatment adherence, either by directly observed therapy or by VDOT. And I can't end by not talking about stigma and fear, which it continues to hinder our efforts in combating not only TB disease in general, but also drug-resistant TB that may be leading to delayed diagnostics and treatment. Now, I've talked a lot about challenges within our Texas program. Our binational TB program manages a lot of drug resistance, as I managed earlier, along that Texas-Mexico border, and it's faced with its own challenges. So I'm going to turn it over now to Catalina from Heartland to present on the binational TB program. So I'll stop sharing.
Like this right here?
Perfect.
Okay. Thank you, Rachel. Thank you, everyone. This short presentation will describe the consultation services provided by Heartland National TB Center to support the binational TB program along the U.S.-Mexico border. I will also share the number of consultations over the past 3 years and the range of cases that we have managed. So over the past 3 years, we have received a total of 410 binational medical TB consultations. Most of the consultations were for adult patients, which made up about 63%. Pediatric patients represented 37% of the consultations. This shows that while adults are the majority, a significant portion of our work also involves children, highlighting the need for expertise in both populations. Most of the consultations that we receive at Harlan are related to drug-resistant TB. You can see here in the pie chart that 89% of all consultations involved drug-resistant TB cases. The 11% of consultation with pan-susceptible TB cases are patients with complex comorbidities or medical conditions such as HIV, diabetes, patients with CNS TB, disseminated TB, and TB during pregnancy. The next slide is going to show a closer look at the 89% of consultations related to drug-resistant TB. So this is the spectrum of drug-resistant TB consultations that we receive. The largest group is newly diagnosed patients with MDR or revamping TB, representing 27% of the cases. In addition, new pre-XDR cases account for 4% of this in this pie. A polydrug-resistant TB cases represents 12%. Together, these three groups make up about 43% of all consultations. This is a significant and concerning proportion. We also see 26% follow-up consultations after completion of treatment, and these include also patients with post-TB lung disease. About 20% of the cases of the consultations are related to contacts to MDR or pre-XDR TB. Overall, this highlights the wide range and complexity of cases that we manage and clearly shows that drug-resistant TB remains a major challenge in the binational setting. So why are we seeing such a high burden of drug-resistant TB along the border? The next slide will highlight some of the key challenges our Mexican partners face in the treatment of TB that contribute to these outcomes. Nearly all the consultations that we receive at Harlan share common underlying challenges. Most of the patients that we receive in consultation have had prior treatment that could be inadequate or not based on standard regimens, or maybe they don't have susceptibility results. There are also differences in how TB care is delivered, including situations where treatment is not directly supervised. As a result, we often see poor adherence or patients stopping treatment early. An important factor is that in Mexico, TB control relies only on voluntary adherence, patient support strategies, and human rights-based approaches, rather than legal enforcement. In addition, the region has limited access to drug susceptibility and drug-resistant testing, which remains a challenge not only in Mexico, but in many parts of the world. Finally, there are gaps in knowledge and training among healthcare providers in managing drug-resistant TB. Together, these challenges make TB care more complex and contribute to the burden of drug-resistant TB in this setting. So this slide demonstrates the impact of our binational collaboration on patient care and program outcomes. Harlan National TB Center consultations have supported the use of shorter U.S. recommended treatment regimens, like the treatment with B-Palm, making therapy easier to complete. The use of injectables has been reduced, decreasing the side effects and improving adherence. Clinically, there had been no treatment failures nor relapses among patients who have completed therapy with consultation support. Long-term follow-up, including 24 months evaluation, has been strengthened. Overall, this collaboration ensures continuity of care across borders and shows how working together improves outcomes for patients with drug-resistant TB. In summary, TB has no borders. What happens in one country impacts the other one. All the binational patients that we support are treated in Mexico with collaboration and clinical guidance from Texas. That's why continuity of care and close coordination between programs are so critical. A strong binational partnership allow us to share expertise and support better treatment decisions. At the same time, addressing social determinants of health is essential for treatment success. Together, these efforts are key to improving outcomes and controlling TB in this region. Thank you for your attention, and now I will pass this to Rachel, who is going to close out our session.
So much, Catalina. So we've shared a lot with you today, and while there's still work to be done, we've come a long way from 1952 when INH was first used in the treatment of tuberculosis. And then in August of 2019, Pertominid was approved by the FDA to be used as a novel all-oral regimen in combination with bedaquiline and linezolid in what we know as the BPOM regimen, really shifting the paradigm of long, complex injectable treatments. We talked about how prior to 2023, we were not able to perform sequencing for some of the newer drugs like bedaquiline, really paving the way to better diagnostics. And in 2025, Texas reported our first patient with bedaquiline resistance and additional mutations, really bringing home the fact that emerging drug-resistant TB is knocking on our back door, which really leads us to where we are today and what's on the horizon. We have monitored trends about drug-resistant TB. However, we must now shift from awareness to proactive interventions. We're seeing resistance to drugs that were new only yesterday, but while the pipeline does offer hope with new active medication trials, as Dr. Seaworth has also outlined in her presentation, with new diagnostics, our immediate duty is to really protect the medications we have now while remaining vigilant for the future. Okay, next slide. That's the end. Just a couple of references for you. So thank you all very much for your time today.
Thank you so much, Rachel and Catalina, for sharing just how scary like drug resistance can be when it's in the context of just not only within the state of Texas, but globally, and as well as highlighting some of the ways that we're already combating it and what we can come up with in the future as far as solutions towards mitigating drug-resistant TB. So we have one final presentation for our World TB Day webcast. I know the time has flown. And so with that, we're going to go ahead and invite Elizabeth Foy up to the stand, the digital podium, so to speak, where she's going to be sharing with us some of the changes that are happening as far as infection control and release from isolation are concerned within the realm of TB. So Elizabeth, please feel free to take it away if you can hear me. All righty. Thank you so much, Elizabeth, for sharing the truly paradigm shifting that is occurring within release from isolation. I know there has been a lot of like, wait, what moments that have occurred whenever we've discussed them with others. So I'm sure that all the information that the state is going to be releasing through those upcoming webinars will be quite valuable to so many of our TB community partners. So with that being said, we have wrapped up World TB Day. Thank you all so much for joining us for the festivities. And then as we close out, I do want to make sure that we share some information regarding continuing education. So while I leave this information on, I am going to turn it very quickly back to Dr. Armitage, who would like to provide some closing remarks on this World TV Day.
Well, I just wanted to say thank you to everybody who stayed with us and joined us for this very important day. And most importantly, just say thank you. There are just every day people that are getting out there and getting it done from, like I said, from CI who walks in and starts identifying the patients all the way down to the DOT workers who are going in there and making sure our patients are seen to, watched over, and medicated. Thank you to every single one of you for everything that you do, and hopefully you'll get some more enjoyment for the rest of your day. Thank you.